हेलो मोबिन सर। हेलो मोबिन सर। हेलो चेक।
हाँ
हेलो।
जी, हाँ जी। अरुण जी, आवाज आ रही मेरी?
हाँ आ रही है आपकी आ रही है सर, ठीक है।
ओके ओके, आपकी
ओके।
भी क्लियर है। वो कैमरा यार करवा दो जल्दी।
बस करवा रहा हूँ, तुरंत करवा रहा हूँ, तुरंत करवा रहा
ओके ओके।
क्या वो हाँ।
या तो कैप्चर कार्ड चेंज कर दो या तो केबल चेंज कर दो उसकी। ठीक है।
सर उसमें मैं इसका कैप्चर कार्ड चेंज करवा रहा हूँ।
तो मतलब शुरू नहीं कर पाए?
नहीं सर प्लीज। कहाँ पे आपका पीपीटी कहाँ पे है?
आई डोंट नो। मेरी आई वोक अप इन द मॉर्निंग एंड हमारे घर में नहीं।
ये वाली है।
नॉट ओनली दैट, माय मोबाइल वाज आल्सो नॉट वर्किंग। इट वाज सो डिफिकल्ट
कौन
टू
सा ये वाला?
कम्युनिकेट
हाँ
विद
जी।
हैं?
हाँ, पहला पीपीटी
all
है
the
ये।
other colleagues from home.
Hello. So very good morning to everyone. Sorry for the delay caused due to technical issues. Today, I, Hamdan, along with my friend and co-host Garima, BSc final year students at Amity Institute of Neuropsychology and Neurosciences, extend a warm and cheerful welcome to all the distinguished members, esteemed speakers, faculties, and participants of Day 4 of the International Brain Research Organization, Asia Pacific Regional Committee, APRC, sponsored 5-day workshop on NEURO-PHARMACO behavioral studies using cell culture and acute as well as chronic animal models. As we embark on this new day of discovery, we continue to be inspired by the passion, curiosity, and commitment that each of you brings to this collaborative scientific journey.
Indeed, Hamdan, today we are poised to delve even deeper into the dynamic realms of neuroscience, innovation, and translational research. Let us make the most of this opportunity to expand our knowledge, strengthen collaborations, and continue building bridges between laboratory findings and clinical applications. We now begin with today's first scientific session, featuring our panel of distinguished speakers. The moderators for this session are Dr. Soumya Pati and Dr. Amrita Pathak, Associate Professors at AINN, and the rapporteur is Ms. Pooja Shukla, PhD Scholar at AINN.
With great enthusiasm, we welcome our first distinguished speaker of the day, Professor Suhail Parvez. Professor Parvez is the Dean of the Department of Toxicology and the Dean of the School of Life Sciences and Technology at Jamia Hamdard, New Delhi. He is also a Fellow of the Royal Society of Biology, FRSB, as well as Humboldt Fellow. He serves as a Nodal Officer for the Institute of Eminence in charge of the Center for Translational and Clinical Research. We have the distinct honor of having you here with us today, sir. We now invite Professor Suhail Parvez to deliver his talk titled Polyherbal Formulation Mitigates Scopolamine-Induced Cytotoxicity Through Acetylcholine Esterase, Downregulation and BDNF-CR CREB upregulations, insight from in vitro and in vivo models.
Good morning, everybody. Good morning, everybody. Good to know you all had tea and a nice breakfast in the morning. So first of all, thanks a lot to the organizers, especially Professor Malik sir and everybody at INN who are more or less a family to me now. Now the guards also have recognized, and I know where to park and where to walk. So IBRO workshop is something that is kind of a great motivation for somebody who is studying neuroscience. And I see some new faces here on my right, which I would assume to be the participants who are outside Amity. Okay. So basically the whole idea about IBRO workshop is to go into this term known as capacity building. And during our times, that was a long time back, we had very less opportunities. I still remember the time when I had my email created. That was only in 2000 when I started my PhD. And the whole difference is very, very unique. Okay, so without wasting any time, what I tried to do in my lecture is to amalgamate few things together and try to make a story out of it. So first of all, very important to know where I am from. Yes, okay. So any of you have heard the word Jamia Hamdard? I think I should be fine.
नहीं sir, audio
Okay. So how many of you have heard about Jamia Hamdard before? Okay. How many of you think that we are a branch of Jamia Millia? None? Okay. So, oh, you still think? Okay, great. So, Jamia Hamdard is actually a deemed to be university that was created in 1989. Before 1989, our courses were affiliated to Delhi University. As of today, we have 10,000 students, 10 schools, and one of the major criterias of assessing any university is NIRF and NAC. So in NAC, we are an A+, in NIRF, we are #1 in pharmacy, and in other fields, I would say we are in the top 50. So when we see an institute, then we see the faculty members, we see the students, and we see all stakeholders. And when we are here in the workshop, the entire scenario changes and we are talking about research. Basically, what you are here for is to get a training for your PhD. But you have to look at the bigger picture, and the bigger picture is this. The fallacy of our country is that we generally believe that the scientific idea has to be generated by the PI or the boss. When we usually ask in the first presentation, why you chose the topic, why this compound, sir ne bola tha. Why this target, sir ne bola tha. So the whole thing has to be changed. Because I am very much sure, at least I can speak for myself, the amount of papers that we are reading is negligible to the amount of papers you are reading. So how we can formulate a hypothesis or write a project by only reading 10 papers? So the idea is you have to summarize those 100 papers into 10 pages, and then we can have a discussion, then I can give my inputs, and then we create an idea. So that is how it works. Workforce, most of the time we are wasting our time running after the files from finance to purchase to establishment, and then most of the time we are making the media, preparing the buffer. The whole idea about this lab technicians is gone. So we have to empower it. And it's not only the PI or the director of an institute or the head will do it. You also have to jump in, because it will make your life easier. So the whole idea again is funding. Funding, you are running after fellowships, and we PIs are running after projects. So this whole thing makes a nice balance. Why? Because the journey is the same. When a fellowship application is being reviewed or a project is being reviewed, there are many things, many criterias that come into play. And today what I am trying to tell you about a particular model or how we develop, you can visualize a couple of things there. मैं रुकूं फिर? Okay, just to know about the audience here, how many of you are undergraduate students, if there are any? Okay, that's very motivating for me. Postgraduate students? Okay, doctoral students? Okay, postdoctoral students? Okay, we have one postdoc. And faculty members? Okay, please tell me who has not held up their hands up and why. Thank you, ma'am. But you still, once a PI is always a PI. You, I couldn't see the hands there, and somewhere here also. So whom did I miss? Undergraduate, postgraduate, PhD student, postdoc, faculty. Whom did I miss?
सर स्लाइड थोड़ा सा ऊपर
It's okay.
मोबाइल सर ये बताओ, ये एक्चुअली में हमारा स्लाइड जो है वो हो गया, जिसका हम व्यू में जाके क्या करते हैं, जिसमें खाली स्लाइड दिखे। हाँ हाँ सर, आपका चेंज हो गया है। इसमें क्या हाइड नाउ, हाँ कैमरा दिख रहा है। उसमें हमें पीपीटी प्रेजेंट हो रहा है ना इतना इसलिए स्क्रीन पे जो शेयर हो रहा है ना यहाँ पे तो शो तो हो रहा है अरे हाँ 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 पीपीटी तो मैं दिखा रहा हूँ अच्छा चलो मैं दोबारा कर रहा हूँ एक सेकंड मैं कर देता हूँ हाँ
चेंज हो तो रहा है, चेंज हो तो रहा है। नहीं, थर्ड वाला ये वाला ये वाला नहीं, इसके ऊपर ये हटा दीजिए, अगले वाले में चले जाइए। हाँ उसी में रहने दीजिए, कोई बात नहीं। कोई बात नहीं, नहीं अगले में चले जाइए ना, इस पे कर लीजिए, ये कर लीजिए। हाँ वो तो चेंज हो गया। इनको चाहे तो बंद कर लीजिए।
पूरा मूवमेंट कर रहा था एक चलता है स्लाइड शो कर रहा हूँ एक्चुअली वो वीडियो आ गया था ना उससे डिस्प्ले पे नहीं जा रहा तो वही करवा रहा हूँ बस 1 मिनट कर दिया है फिर हमारा ये वाला सर्टिफिकेट
हाँ वही उसी पे आ गया, दिख तो वही बना रहा है। पेड़ जो है पेड़ ही पे रहना दो, ये जो पेड़ है पेड़ पे ही रहना।
ये वाला ना
हाँ पीपीटी लगा दो ना बस, पीपीटी का भी छोड़ दो,
शेयर तो करना होगा ना भाई
शेयर तो हो ही रहा है, शेयर तो हो ही रहा है ना, शेयर चल रहा है बस पीपीटी लगा के छोड़ दो, फुल स्क्रीन कर दो इसको। आपको भी यहाँ पे वो कर दो, वहाँ दिख तो रहा है। हाँ लाइट वो कर दो, बस फुल स्क्रीन कर दो।
सॉरी सर
Okay, sorry for the hiccups, but we got a few more participants in, so it's good for us. So when we are talking about the whole thing, that funding, workforce, idea. So the next thing is area. Why? Because it is important for us to understand what are the areas that are getting funded. Not all areas are getting funded. And when we are talking about health and research, these are actually the disciplines that are there from the core, whether it is pharmacology, microbiology, immunology. So these are the textbooks that we are reading. These are the disciplines in which we are getting trained for studies, for practicals. But when we are talking about the trends or the areas where we are getting funded, so these are the basic 4 or 5 areas where majority of the projects are getting funded. So as this is a neuroscience workshop, so we should definitely talk about neurobiology. So the next thing comes, once you are set up for a project or a fellowship or your own work of neurobiology, what are the tools that you are starting with? The idea comes a little later. First, you need the complete cartwheel of the techniques that are actually there in neuroscience. And they are plenty. Half of them are dedicated to neuroscience. For example, when you will be doing animal behavior. So animal behavior is hardcore neuroscience. Maybe other disciplines can take as a corroborative evidence, but for you it is completely neuroscience. Or when you will be doing electrophysiology, or when you will be doing stereotaxy. So these are hardcore neuroscience. But when you come to the other part, for example, cell culture, for example, flow cytometry, RT-PCR, molecular biology techniques. So these are the techniques that are there out for everybody. So once you build your career, or when you plan something out, you need a mix of both. So any particular lab or any particular department or even an institute, if they would like to cater for neuroscience as a whole, so this is something that should be there. And I'm very proud to say, because I still consider AINN as my family, that AINN has gone a long way in creating this cartwheel. And I think very soon it will be completely done. So that's something which is important for IBRO to recognize, and that is why such a program has been funded. So you know that if you want to build a career in neuroscience, everything is there, but this is also very important because you have to showcase how your ideas will be executed. They will be executed with help of experiments. Experiments will be done with the help of techniques. So once we are done with this, let's try to understand a little bit of neuroscience. But why do I have movie slides in my PPT? Because I would first like to test your knowledge for Bollywood. So let's go about it. Let's go one by one. Let's see if we remember the movies we have. Okay. All. बहुत अच्छे से अपने आप ने पैसों का वसूली किया है. Go back and tell your parents that whatever they have given you as pocket money has been completely utilized. Now, let's go back to neuroscience. Neuroscience, let's talk about the syndromes on which the movies were made. Let's go again, one by one. See the difference? सारे पैसे waste हो गए. Whatever movies you saw, whatever the songs you remember, makes no sense because neuroscience was at the core. They took the ideas of the syndromes and made millions of rupees out of it from your pockets. So our knowledge is very limited. Why? Because we are only abreast. If you talk about a common man, when you say neuroscience and you say neurodegenerative diseases, they will recognize two things. एक हिलने वाली बीमारी होती है, एक भूलने वाली बीमारी होती है. That we call as Parkinson's and Alzheimer's. And then you go about एक हंटिंगटन भी होता है, वो नहीं सुने हैं. एक एम्यूलॉइड लैटरल स्क्लेरोसिस भी होता है, वो भी नहीं पता है. So things like this is very important that you have to understand that if you are writing a project on AD or a PD, practically everyone who is working in neuroscience will be doing it. So how difficult it will be that out of 200 or 300 proposals coming in, you will fare in the best 5 or best 10, because you have absolutely no idea what the other 99.99% proposals are about. So sometimes you have to think, okay, it may be the same, but why don't I change my track? Because again, everything is neuroscience. So think about it, that, and not run after the field what everybody is doing, because then you have to be very specific. You need to build up transgenic models, you need to do something out of the world. For cancer, you need maybe something with xenograft, and those facilities are not very common. When you become a PI, come to an institute, and an older faculty will say, AD तो हमारा domain है, आप कैसे काम कर लेंगे? So things like this will then demotivate you. So look for a broader picture. So once we are done with this, let's talk about the diseases that we have. And whenever we are talking about a disease, we should first think in different terms. We have to differentiate neurological disease towards neurodegenerative diseases. And there are plenty. If you look at the proposals, at the research papers that are coming out, they are a mix and match of everything that has a neurological basis as well as a neurodegenerative basis. So what you need to do is, you need to create a balance. But at the core of it, definitely lies something which we call as models. And usually what we have in our mind, whether it is neuroscience, whether it is diabetes, whether it is rheumatoid arthritis, the health sector is divided into the epidemiological basis. How much is the population being affected? Is there a medication that is available? How good your research will be if you are looking for something which is a pathway that has not been explored, a drug that has not been tested, or any other thing that is in and around a particular disease. So basically, what we are talking about as an example, I am taking dementia. So the epidemiology is huge, because when we are talking the numbers, they are plenty. The day by day increase in our lifespan and the quality of life is only adding to it. And when you actually look at the epidemiological basis, you can see that 60 to 70% is basically Alzheimer's. But when you look at the others, though the percentage are very less, but still they are also substantial. So if you look at this cause randomly, then you will be saying Alzheimer's, okay, best is beta amyloid because the plaques are involved. So I think ICV infusion of beta amyloid in a rodent model would really solve everything. Now, when we are talking about the pathophysiology, there is not only one player. There are so many different things that needs to be catered for. For example, when you are doing the experiments in a rodent brain and you are taking out the entire brain, when you are talking about anatomy, physiology, and all other aspects, then there are different lobes, then there are different organs. So should I take out the hippocampus because it is the center for learning and memory? Should I go for the prefrontal cortex because in dementia that is more important? So all these things will only come to you when you have your basics right, when you really go through the textbooks. So pathophysiology will always give you certain new targets, certain old book schemes, but overall an understanding. When you look at the global market, the whole pharmacological paradigm of drugs that are being used and the economy that is being there is tremendous. This particular drug, Aduhelm, came to the market only 4 years ago after a long period of being in clinical trials. But of lately, after 4 years of this approval, reports are coming in. There are still some lacunas and deficiencies, and we cannot really trust what has been projected. The economy, the market is growing like anything. You are aware about the pharmaceutical companies and the money that they are pumping in. Okay, so this whole drug repurposing has come up in a huge way. You may be aware about drug repurposing, where you have identified any other new drug that will actually bypass certain phases of clinical trials so that your discovery is a little faster. So based on this, let's now come on what will be the models. Very favorite of everybody post-COVID, docking in silico. And practically everybody is doing it. There are few softwares that are free, few which have a license, and technically we are getting a hit out of it. As I am reviewing proposals in the funding agencies, practically every proposal has a preliminary data on docking. But this again has a negative impact because everything cannot be achieved by that. The next thing that we have is in vitro, a cell culture. Few IACs, the Institutional Animal Ethics Committee, when you submit a proposal, they would like to have some kind of a preliminary data for the justification that why do you really need the rodents to actually do your experiments. So something related to the cell culture can really help you, and in this you have to obviously cater for a particular cell line that actually will give you your desired results. Not only one cell line is out there, for the neuronal aspects also, there are many cell lines that are there in the market. When we are talking about in vivo, definitely we have the mice and the rat coming up as the best rodent models. But I am telling you, these days, maintaining an animal house year after year is also not easy. The costs that are affiliated to animal house are enormous. That is why the funding agencies have been very generous. If you can justify animal experimentation, you can ask for specific amount of money for animal studies, and that is quite generous. So, okay, yeah, one point here. So if you would like to do, let's say, an animal experimentation, we would like to infuse the ICV with beta-amyloid. Just for this small thing also, you need a stereotaxic apparatus. Why? Because you have to inject 2 or 4 microliters of beta-amyloid in each of the hemispheres. That will also happen with a micro syringe, a stereotaxy. You need to learn about the coordinates. That means proper training. There are avenues where you should do animal experimentation with proper handling, proper ethics, proper guidelines that we are always bypassing. It is like senior se seekh lena. This you should avoid. Even if it's a week or 10 days training, it should be part of that. So then you have agents that we are using to induce the diseases. Usually in Alzheimer's, we have these 3 agents that are being used: beta-amyloid, scopolamine, streptozotocin, and it is not limited only to AD. Whatever disease you are studying, there are so many different agents that are there and that are used. So choosing a particular model, choosing a disease, choosing a particular agent to induce the disease, all of this is interrelated. That is why the first thing that we are doing now, still in some labs, is that the scholar is coming, sitting in front of the PubMed, making the synopsis as the first task, and being guided by the PI or by the juniors key. This is the field and first you make the synopsis. That should be actually the last step. First thing what you should do is learn the basics of any field that you are there and get a feel of all the techniques that are being done in the department and outside the department. Why? Because until and unless you know the overview, how you can explore your field, there is no point. You have absolutely no idea what is the difference between a rat and a mice. कौन सा बड़ा होता है, कौन सा छोटा होता है. Why a particular gender should be used for a particular experiment. How you can just write up your synopsis. So that is why this again is a big challenge, and sometimes it happens. It is very, very difficult to do the 6-OHDA rotenone or MPTP experiments with Parkinson's. Much, much difficult as compared to the Alzheimer's disease. Okay, so let's jump to beta-amyloid scopolamine. Now, why exactly I chose scopolamine when already beta-amyloid with its ICV function going into the brain is already available? So the difference is that when we are talking about beta-amyloid, we are talking about the whole cascade that is responsible for Alzheimer's disease per se. But what scopolamine can provide, it can do two things. First of all, it will mimic the cholinergic dysfunction. A lot will also depend what particular intervention you are using, because your intervention will be following and targeting a particular pathway. So whether the model that you are using or the agent that you are using is actually giving you that perspective or not. So scopolamine is something that is working on the cholinergic hypothesis. So any agent that will follow that paradigm will benefit from using this as the agent of dementia. So scopolamine is actually an alkaloid from the plant species, and first of all it was known for its hallucinogenic effect, then the anti-muscarinic action came into picture, and of lately it is being used as a model for many, many rodent studies. So what we did is we chose the neuroblastoma cell lines for our experiment, and we came to the agent that we were using. Oh, I think it's there. Yeah. So, okay, yes, this particular slide I wanted to show you how you have the different cell lines, and the cell lines have different origins, even targeting different neurotypes. These information is very important. It's just not that my lab is running SHY, so I was doing my experiments on SHY. So these experiments are very important in convincing the IAAC that you have actually some preliminary results. How much time do I have? Because we had some interruption. Okay, good, thank you. So when we are talking about the rodent models, whether a rat or a mice, very important. Not only the gender, but the age. Age is also very important. You should be in words with the veterinarian. We are only talking about it when our proposal is selected. We just go and order as if we are ordering from Blinkit. No. How do you believe that the animal age that they are telling you is what actually is? If it's a 4 week, 6 week, 8 weeks, study from the literature when the adult receptor functions are really done in a rodent. It takes no less than 8 to 12 weeks. If the adult receptor function is already not done, if you are using a 6 weeks old rat, how you can justify? So caring for the animals is very, very important. Familiarity with the animals when you are doing neurobehavioral experiments is tremendous. Because if you are not properly trained, you will just lift up the rat. The moment it jumps, you will also jump. Animal neurobehavioral experiments are one of the most difficult experiments because the rat has to be familiar with you. Then only it will show you the results, otherwise it will show you permanent freezing behavior. And then you will say response, no response, nothing in between. Very, very important for you to understand that. So usually scopolamine is induced through IP. Now, I was working on repurposed drugs. This was the first time that I ventured into traditional medicine because of a CCRUM project I got. And Bacopa menori, the plant, this is known as Brahmi in mostly all the forms, whether it is Ayurveda, whether it is Siddha, whether it is Unani, all of them have it. And in Unani it is known as actually Majun Brahmi. I think the other one. This one is. Okay. So, what our idea usually is with traditional medicines, we always go for the constituent. Okay, this is there, and this is the major constituent that is there. Let's go with this, and let's order this, and then it's done. Well, cell culture studies or animal studies, for me, it is important that you take the whole extract. Later on, you can go for it, okay, which particular thing was there. So we did certain experiments with Drosophila, because Drosophila is one of the alternate models, and Drosophila neurobiology or the Drosophila neurobehavioral experiments give you excellent results. And the best part is you can also use transgenic Drosophila strains very easily. Okay, so we did a few experiments with this, we did some in silico, we did some cell culture, and finally we got the animals for our studies. Now, whenever you have, because my main focus was to tell you a little bit about animes and how exactly these things are done, you have to familiarize the animals, as I was telling you. So usually it's a one-person show. Whenever you have the animals, you take the animals and you have to spend time with the animals. It's just not just taking 4 animals from the animal house, taking it, doing the reading, and no. You have to spend time. And these pre-acclimatization phase is the one that is most important. Otherwise, what will happen? Somebody is doing neurobehavioral, somebody is doing the treatment, somebody else is doing the post thing. Why? Because on Sunday you have to go and watch a movie. Meri dosing kar dena. Very, very discouraging. So, just to give you an example, like this is a novel object recognition experiment. So, what you have is, you have 2 similar objects initially, and then you change one of the objects. Actually it is here. This is one object and this is one object. So one of the objects here, and the way the animal will actually move is being captured by the software. And you can easily trace the path that I have taken, and then you can plot it. So each neurobehavioral experiment, each paradigm is specific for the function that you are being testing. You can easily corroborate the neurobehavioral experiment with the biochemical estimation towards the molecular marker and finally the immunofluorescence and histopathology. So if you follow this study, that would really test your hypothesis at the core. So this paper actually is currently in revision. So we did the NOR experiments, we did the Barnes maze, very typical, water maze, Barnes maze, Y maze. So I saw in the program there is somebody else who will be talking about the neural paradigms and surgery. So very important that you get to know the difference between the mazes, why something is more important, what exactly you will be finding out with your experiments. So basically the hippocampus and prefrontal cortex, these are the two areas that you can study for dementia. So when you are talking about hippocampus, very important, the concept of mitochondria. So when you have the mitochondria, you have the outer mitochondrial membrane and the inner membrane, and there is this permeability transition pore that is in between. So if the ROS increases, the membrane potential goes down, there is this leakage of the PTP, so the cytochrome C comes out and it may activate the whole apoptosis cascade. So flow cytometer, very important technique. That was there again in the cart field. We had the animal behavior, we had the flow cytometer. Very nicely you can use the fluorescence dyes to get the ROS, to get the MMP, because that will set up your role to go next when you do the Western blots, whether of the neuroinflammatory markers, whether of the anti-apoptotic, pro-apoptotic BAX BCL2, and whether to look at the cytochrome C, whether more of it is in the cytoplasm or in the mitochondria. So again, the whole molecular biology paradigms where you do the Western blot, you do the preparations, and you can see whether the normal protein or the phosphorylated version is there. So these experiments again become one after the other when you plan your experiments. Then you also have things which will be leading to the neurotransmitter estimation, would be leading to the immunofluorescence or even certain enzyme expression via the histopathology. Okay, so time is very limited. So basically the whole idea is that whenever you have this, you can even compare the different regions, what happened in the hippocampus, what happened in the prefrontal cortex. So once your story is done, then you go back to your hypothesis and check what were you thinking, whether it is doing absolutely nothing anywhere, or if it is doing something in somewhere, how exactly you project it, how exactly you come up with your story, because that is the basis of your paper. Not all parameters will work. Sometimes you have to also repeat the experiments and you may be seeing different effects. All that troubleshooting is only up to you. Your PI will only come in between, but majority of the handling, majority of the work that you are doing, if you are trained properly, then only you can do it. And IBRO workshops are the greatest platforms, in my eyes, where you get such a nice overview. Okay, so this is how we actually showed the role of CREB and BDNF, and we employed huge number of techniques by which you can show. So the whole idea thing, the cartwheel is very important. So my time is over, I am just about to finish. So these are the funding agencies that have helped me over the years. I am very grateful, but the real heroes of these are my wonderful collaborations that I have and the students who have been there with me for the past 15 years. The faces change, but their commitment and their dedication doesn't change. So thank you very much.
The forum is now open for discussion. I request everybody for their active participation.
So I had asked Dr. Rachna about the audience because whatever funding has been given is only because of you and for you. So I didn't want to really focus on the results. I wanted to give you a whole bigger picture about it. But anything that you feel like, you can ask. No questions? That was, oh, you have some. Thank you. I was very disappointed.
Okay, good morning, sir. My name is Abhijay. I am a third year student from ANN. I wanted to ask about the figure which you showed at the end, the pathway and all. I saw the glycogen synthase kinase beta was getting inhibited by the AKT. That arm was also there. So, did you consider using okadaic acid as a model for inducing Alzheimer's disease-like symptoms because of its inhibitory protein phosphatase activity and particularly focusing on that pathway and tau hyperphosphorylation aspect?
So basically, what the project was all about was to check only the formulation of Majun Brahmi in different types of dementia. So this was the first part done. What we wanted to show that when we are looking at the overall picture, because scopolamine is inducing an overall dementia. That is why we took the hippocampus. That is why we took the prefrontal cortex. So personally, I have not worked with okadaic acid, but I have worked with definitely with beta amyloid and with scopolamine. So the next idea would be to then segregate them, and from this dementia to go into the beta amyloid model, and then focus on the Alzheimer's, because when we will be doing Alzheimer's, the Barnes maze will change into water maze. But literature definitely says that yes, okadaic acid is one of the agents. I don't know, it will only depend on the next set of experiments, because we wanted to first check out like whether in overall dementia it has a role, because it has been used for ages, and currently at least Majun Brahmi was never being reported. So that was one of our targets.
Okay, just one more question. You told that, like I was in literature also, there are abundant phytopharmaceuticals being tested as therapeutic agents for Alzheimer's disease. So you said that rather than using a particular extract or a constituent of that particular plant, we should use the whole
Initially, for the first time, because everybody in the literature, they are saying that okay, this constituent is there in the extract, so we purchased a purified constituent and then we did the experiment. But we will never give a purified constituent to the patient. We will always give an extract to the patient. We will not say, okay, I have isolated this, so you will take 200 milligram of this. It will always come as an extract. What we can do is, definitely not one, but maybe 4 or 5 different constituents will be there. So we can collate the role of each and then come up. But yes, the first evidence what we need to show is whether the whole extract per se is really working or not.
The extract, generally, won't it have a relatively weak effect or mild effect?
It doesn't matter. It doesn't matter. It doesn't matter, because overall, that only, whether it is weak, strong, it doesn't matter. The extract as a whole, that is being given to the patients, because we actually deducted or deduced the dose from the patients to the animals by the normal regime that is there. But nobody has shown that. So once we have shown, okay, something is there, then we go about it.
Understood. Thank you very much.
Since we are running late of time, this would be the last question for this discussion. You can meet sir during tea for more of your questions. Thank you.
Hello, I am Yogita Adlakha, a faculty at Amity Institute of Molecular Medicine Stem Cell Research. You have worked tremendously on in vitro and in vivo models. So do you have some plan to test these findings in human stem cell based model as well?
Yes, I have a collaborator now. I personally am not working on stem cells, but I have a collaborator now, and we are trying to go to the next step. We are also planning some clinical trials about it. but everything is at a very nascent stage.
Thank you.
Thank you everyone for your active participation. Thank you, sir, for that inciting and insightful presentation. Your work highlights the potential of integrative pharmacological approaches in combating neurodegenerative processes. We now request the moderator of the session, Dr. Amrita Pathak, to kindly honor the speaker with a token of our respect. Thank you, ma'am. Thank you, sir. As we reflect on Professor Parvez's valuable insights, we are honored to introduce our next esteemed speaker, Dr. Manish Baldia. Dr. Baldia is the Professor of Neurosurgery at ECI Medical College, Hyderabad, and the Director of NICE Brain Private Limited, Mumbai, India. Dr. Baldia is a functional neurosurgeon and deep brain stimulation specialist focusing on advanced treatment of Parkinson's disease, dystonia, and movement disorders. With over 120 DBS surgeries and 1,000+ advanced programming sessions, he combines precision neurosurgery with compassionate patient-centered care. His expertise lies at the intersection of stereotaxy, neural circuit recording, and neuromodulation therapy. We are privileged to have you here with us today, sir. We now invite Dr. Baldia to deliver his talk titled Stereotaxy, Neural Circuits Recording, and Neuromodulation Therapy, a PhD and postdoctoral workshop in translational neuroscience.
Thank you so much for the kind introduction. Today's talk will be more of for many of you will be very inspirational. What you are doing is more of animal experiments, but your foundational work, how it is getting translated into clinical practice, that we will be able to see. And there will be many questions open and many areas to work on the clinical research part. So if any of you are interested in electroneurophysiology, they can explore these areas, that how this mechanism works in human beings, how it works, this electroneurophysiology in the human brains. So my entire talk will be on the electroneurophysiology in the humans. So starting, yes. So always I respect my parent institute where I did my post-graduation neurosurgery course, 6 years. This is the first neuroscience department in South Asia, where the neurology, neurosurgery, neurochemistry, physiology, anatomy, physiology, neuropharma, everything, the entire department was set up in 1949. Recently we celebrated Diamond Jubilee also. And at this institute, I have learned the basics of stereotaxy. We had 2 animal labs and stem cell center. So I have utilized this institute properly. Along with my clinical practice, I have also done basic research in stem cells, in regeneration of intervertebral discs. I also worked on the implant manufacturing, cranioplasties. I worked with biomaterials. So with all this foundational work, I have gained much experience in the neuroscience practice. And today, I have become functional neurosurgeon. So if many of you might not be aware of the terminology functional neurosurgeon. So functional neurosurgeon deals with all the functional disorders of the brain, like Parkinson's disease, dystonia, movement disorders, psychiatric disorders, or pain disorders. So we try to modulate the brain circuits and try to control these symptoms through the electrophysiology treatment. So these are all reversible treatment. We do not cut or join any circuits, but we are just modulating the circuits with the help of the electrophysiology. So that deals with the functional neurosurgery. So we are very well versed with the stereotaxy and neural behavior, brain behavior. Currently I'm practicing in Wockhardt Hospital in Mumbai, and I'm also associated to the ESI Hospital in Hyderabad. And I visit multiple places in the Wockhardt group of hospitals. I'm also an entrepreneur. So with this, all the basic experience in the CMC Vellore, I've set up my own company called NICE Brain Private Limited, where I am manufacturing the cranial implants. It's a 3D reconstructed implants for the human skull. I have established the ISO 7 clean room facilities and ISO 13485 recognized facility. We are also manufacturing new neural devices which are helpful in the clinical practice, like spinal cord injury detector and roadside. In 2 seconds, you can detect whether the patient is having spinal cord injury or not before lifting him up from the roadside. In that way, you can prevent secondary spinal cord injury. And I also designed a device where it will detect the human body fluid drainage in the real-time monitoring, and you can control it remotely, that drainage, and then also it will give you all the biochemical parameters remotely. So without sending the sample to the lab, within 2 seconds, you will get the biochemical analysis of the fluid. So neuromodulation surgery, it deals with all the brain circuits, and we all know that brain is the CPU of the human body system, and it controls all the functions, whether it's digestive or cardiovascular, or it's reproductive, or it's degenerative, whatever the degeneration happens, that also starts with the neural thing. But yes, there is something called as gut-brain axis, which the systems are all interconnected, and each consequence leads to the degeneration of the other parts. So the main part, we all know that basal ganglia is the main circuit which controls various movements in the body. So basal ganglia mainly is the programming structure which facilitates the smooth movements of the body. So execution, the planning happens in the basal ganglia, and then later on execution happens through supplementary motor area, premotor area, and motor area. So, so the nucleus involved in this are actually very important for various degenerative disorders. So when there are different disorders in the different circuit levels, like for example in the Parkinson's, the degeneration happens in substantia nigra, thereby the dopamine production gets reduced, and when the dopamine production gets reduced, 3 types of systems get affected in Parkinson's disease. That is, first one is motor system, which is very evident, which affects the quality of life. The second system is autonomic system, that is cardiovascular or digestive system. That is also because of the dopamine reduction. The third system is psychological. So patients become stubborn, selfish, depression, labile mood. All these are because of the dopamine reduction. Those are mental illness or Parkinson's. So Parkinson's has 3 systems disorders. It's just not the tremors or the bradykinesia or rigidity. It is the 3 systems which gets affected in Parkinson's. So similarly, Huntington's, similarly hemibalism. So all these are disorders in the circuit. So we try to modulate at this circuit level. So the dopamine chemical which is getting translated into electrical energy at that, and then that is facilitating the circuit. So at that circuit level, we are inserting the electrodes and trying to provide external electrical energy to facilitate the smooth body movements. So in the movement disorders, commonly we see tremors, dystonia, chorea, dyskinesia. How these movement disorders look? Many of them might have not seen. So this is called tremors. This is oromandibular dystonia. Whenever the patient tries to speak, there is stiffening of the platysma muscle, jaw muscles, posterior neck muscles, facial muscles. So he's not able to open his mouth, he's not able to talk. So this is called as oromandibular dystonia. This is a disorder in the basal ganglia. This is generalized dystonia, involves head, neck, trunk, limbs, tongue, mouth, legs, everything.
Thursday, Friday.
So that is generalized dystonia. These are tics. So this is also a movement disorder. It's not a psychiatric patient. It's a movement disorder. And this is writer's cramp. He has difficulty only in writing, nothing else. That is called as task-specific dystonia. Only in that task he has difficulty. He develops pain in the hand, the wrist twists. But if he's doing other work with that same hand, he has no issues. The power is good, the muscles are good. If you do EMG, all the muscles are functioning properly. But only when he comes to writing, there is difficulty. So that is called as task-specific dystonia. This is a classical Parkinson's disease patient. Parkinson's disease always starts from one side of the body, never symmetric. It is always asymmetric. Starts only on one side of the body, starts with 1 or 2 symptoms. Need not be necessary that there should be tremors. It can start with slowness, it can start with rigidity, it can start with freezing of gait, but it is always asymmetric. After 2 to 3 years, it progresses to the other side. So Parkinson's is a clinical diagnosis. No laboratory tests are required to diagnose the disease. Okay. So the diagnosis is very important because to prognosticate patient, there are similar kind of disorders like progressive supranuclear palsy, multisystem atrophy, corticobasal degeneration. All these mimic like Parkinson, but those are not Parkinson. And those disorders do not improve with this deep brain stimulation or electroneurophysiology treatment. So that's why it is very very essential to differentiate between the diseases so that we can actually counsel the patients that which treatment will work for them. So we start with the dopamine replacement. There was a dopamine agonist drugs, levodopa drug, COMT enzyme inhibitors, MO enzyme inhibitors. All these drugs facilitate dopamine in the body, and they may try to maintain the high dopamine levels in the blood levels, and thereby their circuit opens up and they get very smooth movements. So initially these patients do very well. So initial period is like honeymoon period, 3 to 4 years, very well, everything is going good. You take just half tablet, it works for 8 hours, 12 hours. But after a few years, they develop resistance, they develop tolerance. Now what is happening at the receptors, we don't know. So the receptors, they develop tolerance, they stop responding to the same doses. So we have to increase the doses. Now we don't know how much is the requirement for the particular patient. In humans, for normal patients, usually it is secreted as per the requirement. Morning it might be 50 microgram. When you are stressed, it might be 100 micrograms or it might be 1000 micrograms. But for a patient, we don't know at what time which dose is required. So, but as a clinician, what we are doing is we are pumping the dopamine every 4 hours or every 5 hours, 125 mg, 125 mg, 125 mg. Whether it is required or not, we are pumping inside. So what happens to the receptors? Receptors stop responding. When someone is calling you 10 times a day, what do? You block him, you stop responding. Then again he takes another number and again calls you, what do? You block that number also. The same thing is happening with the Parkinson patient. We are giving him 4 times a day. For initial 2 months, he will do well. But again, that 4 times also will not work. Then you have to increase it to 6 times. Then you will have to increase to 8 times. Like that, there are patients who take dopamine every hour. They keep the tablet in the pocket and they keep chewing. So when they are taking such a excess dopamine, all this dopamine is not absorbed. This is freely circulating in the brain. And it disturbs all other circuits, memory circuit, it disturbs behavior circuit, they lose memory, they lose their cognition. So all these are side effects which develops due to excess dopamine circulating in the brain. But we don't realize patients want that the result, so we keep on giving the medicine. So that's how the receptors also, what I have noticed is, as you keep on pumping dopamine, the circuit also gets damaged. So initially at half tablet, the effect what we were getting is 100%. Means he used to become like normal. You can't differentiate between him and the Parkinson patient. But now we are giving 2 tablets, but still there is no 100% improvement. Only there is 70% improvement. Why? Because the circuit also is getting damaged day by day. So that's what is happening with the prolonged usage of the medications. So coming to the, so finally these patients have to land up in the DBS therapy, deep brain stimulation. So there comes the principles of this stereotaxy. So we'll discuss about the stereotactic. Stereotactic is the word used for humans. When we do stereotactic procedures for the humans, it is called as stereotactic. When you do on animals, it is called as taxi, stereotaxy. Okay, so stereo means 3-dimensional, taxis is position. So these are the initial stereotactic frames. The first brain localization was done by Broca's and Huglings, and then first frame was developed by Horsley and Clark, and that was used for animals. And the first frame here, stereotactic frame for the humans, was developed by Mason in 1918. And then later on, Lexel frame came, which was widely accepted worldwide and widely used also in 1949. And since then, there have been multiple stereotactic procedures been started on humans. And initially, all these procedures were designed for psychiatric behaviors. So those days, psychopharmacology was not so great. There were not many drugs to treat the psychiatric conditions. So all the neurosurgeons were doing psychiatric practice. So they were all doing psychosurgeries. So these are the different types of frames currently available. Spiegelweis, that is translational system. arc system leg cell, bar hole mounted frame. Then we have interlocking arcs, that is BRW frame. So BRW also is very famous, and currently I'm using this BRW frame. This is the mounted frame is called as CRW. It has very good accuracy, is very sturdy, and the calipers are also very good in this CRW frame. So the evolution of DBS, how did it start? So initially, people used to do these psychosurgeries by creating lesions with the electrodes in the brain. And when they used to create the lesion is a destructive procedure. You are actually increasing the temperature in the electrode and trying to destroy that part of the brain or nucleus of the brain. So when you are doing that, before doing that destruction, you do 100% confirmation whether you are destroying the right structure and there are no side effects. So before destroying, we used to deliver current and see what are the effects coming up. If the patient is developing any side effect, then we used to not destroy that. But if the patient is developing the therapeutic effect, like if the tremors are stopped, or if the patient has developed the smooth flow of the hands, the rigidity is disappeared, that means we are in the right target. So after confirming the result only, we used to destroy that part. So by destroying that circuit, we used to get good result. Now how that works, we don't know. Actually, by destroying, you are actually interrupting the electrical current transmission, but that is actually causing good effect. So then people realize why to destroy it. Let's develop a tool where we are constantly able to deliver the current, because we are getting the result whatever we want. So why to destroy it? So that's how the evolution of DBS came, and they started using, they developed the pacemaker, which has a constant current, and then they developed electrodes also, which can be kept in the brain for longer years. And gradually, now the pacemakers which have come, they last for 25 years. The battery life is 25 years. So there are lesioning techniques and deep brain stimulation. So lesioning they are also minimal invasive. Now we have developed non-invasive also, that is magnetic guided ultrasound, where you can destroy the certain nucleus or circuit in the brain without doing any incision through the ultrasound waves. So that is MRGFUS. But that has its own limitation, because you don't have a real-time confirmation which structure in the brain you are destroying. There is no real-time confirmation. The real-time confirmation happens only with electrophysiology. You deliver the current, you see the side effect, then you know, yes, this is the correct structure. But based upon the imaging, whenever you are trying to destroy, it always has an error, because the rays has to pass through the skull, it has to go through the CSF, it has to go through the parenchyma, and it can get deviated. It can get scattered. So because of that, you might be thinking that you are destroying the right structure, but actually it is delivering to the wrong structure, and you can develop permanent side effects. So thereby, lesioning becomes a little bit riskier, whereas DBS is always reversible. You can just turn it off or steer the current in certain direction, and you can avoid the side effect. So for Parkinson's, it's a gold standard treatment now. We are doing this deep brain stimulation. And up to the age of 80, you can safely do. Only contraindications are if the patient is having severe cognitive decline or memory deficits or behavior disorders, then yes, you need to revise your target. So what exactly we do in this? So we drill 2 holes in the skull of 14 mm. And then we insert 1.5 mm thick wires, and we connect with a connector electrode with the pacemaker, and it constantly delivers the current inside the subthalamic nucleus or globus pallidus internus nucleus. These are the 2 targets for the Parkinson's. Based upon the different etiologies, different pathology, the target keeps changing. So each target has its own benefits and risks. So the entire planning is done on the computer, where we select the target, and we also select the entry point. We calculate the distance. We also screen the entire trajectory, whether there are any major blood vessels in between, or whether there are any major fibers in between, eloquent tracts, which should not be disturbed. So all the entire trajectory, each mm wise, we screen it, and we make sure that it's a safe trajectory. With this, we get the coordinates for the stereotaxy frame. We get X, Y, Z arc ring. And these coordinates, we place it. So we fix the frame. This is how we fix the frame on the patient head. 4 points, 4 screws on the frontal area of the 2 on the frontal and 2 on the occipital. After fixing, we place the localizer. This is the localizer. So this diagonal has a marker which is detected in the CT scan. So then we do the CT scan. So once we do the CT scan, that's how it is localized. All the 9 coordinates, all the 9 points are visualized. And these points are registered with the MRI, the MRI on which we have done the planning. So once we register this, we get the frame coordinates, 5 coordinates, and we position the patient head. It's above the bed, it's in the air, so you need to lock properly the head and the frame. If you miss or if you do not lock it, the head will fall down and patient can die. So fixing positioning is very important because is the main head what you are working on, and you are going to apply pressure also on the head when you are drilling it. So you need to see whether that much pressure it is going to withstand or not. So whoever the attenders are locking, we need to make sure, double sure that it is locked properly. Otherwise it can lead to catastrophe. So then we make the burr holes, we insert the electrodes. This is a MER electrode. Sorry, it's stuck. Yeah. So this thin micro electrode we insert to the guide into the patient head, and as we go inside, we start from 10 mm above the target, and each we keep on recording the micro electrode recording, and we get the firing of the neurons. So the MER firing. So micro electrode recording we connect all those wires once we insert the MER electrodes into our recording system. And so what we actually record is single unit neurons firing. So we get all the firing of the subthalamic nucleus. So subthalamic nucleus has characteristic firing, globus pallidus internus has characteristic firing. So once we obtain that typical firing, we come to know that yes, we have reached the target. Then we see how much depth we have penetrated the target. So the nucleus, subthalamic nucleus is 6 into 8 into 6 mm. So whether we have obtained the entire 6 mm trajectory or not, that nucleus. So we have to be on the posterolateral part of the nucleus, not in the center of the nucleus. Posterolateral part of the nucleus has actually the motor neurons related to the Parkinson's. So you need to activate those neurons which are in the posterolateral part. So imagine in the 6 mm nucleus, you have to be in the posterolateral part only. So you have only in 2 mm. So in 2 mm, you have to insert this 1 mm electrode. So this is a precision-oriented surgery. You cannot miss the target. So these are the various nucleus and various firing. The differences between the MER recording firings, how do we get? And this is how we identify whether this is subthalamic nucleus or globus pallidus internus, or whether it's VIM nucleus in the thalamus. And then when we are recording the MER, these are the settings we put. We put the filters, and then we do the sampling also, and then we amplify the gain, and so that we see the firing of the neurons. And then we use the microstimulation with 130 Hertz and 60 pulse width. So when we enter the subthalamic nucleus, this is the characteristic firing, like rain falling outside, the raindrops firing. So that is the characteristic firing of the subthalamic nucleus. You increase the background is increased, the firing rates are increased. +3. And then once you come out of the subthalamic nucleus, once you enter the substantia nigra, all the sawtooth waves goes off and you get a uniform waveforms. So that means you are in the substantia nigra. We post-process this all signals, and then we see in which trajectory we have got. So we insert 3 MER electrodes, not 1, 3. Central, lateral, anterior, or central, medial, posterior. So we decide based upon the anatomy of the subthalamic nucleus, and then we choose 3 trajectories. Out of 3, which is good, we select. 2, we select the best MER firing, and then we start giving the current. So this is a live interactive surgery. talk to the patient, and we
Very
see the
nice.
response in the patient. Patient himself confirms that he has got the result.
Hilaiye. How is it now? Good? Tightness improved? Okay. Leg? Is better.
So we don't give
Very
any
good.
dopamine medications on that day,
This-
so that he's stiff. There is good rigidity, good bradykinesia. And then when we start the surgery, when we give stimulation, we see the response in the patient's hand. And we confirm with the patient that whether you have got the same effect like medicine or not. So patient also moves his hand and he checks which one is good, whether trajectory 1 is good or trajectory 2 is good. And we give different amplitudes also. And he again checks his hand, we check his speech, we check his extraocular movements, we check his leg movements. All these movements are assessed during the surgery. So this is awake surgery. And you get real-time results. So we are trying to actually identify the sweet spot. There is a sweet spot in the subthalamic nucleus. Not just by entering the subthalamic nucleus or stimulating the subthalamic nucleus, you will get the result. You need to identify the sweet spot, and we don't know where is the sweet spot. Yes, this MER helps in identifying the sweet spot, but it takes a lot of time in post-processing. In OT, we don't have that much time to process all the data, because it has to be taken to the MATLAB, and then we have to take out all the bad signals, and then refresh it, amplify the signals, and all those time we don't have during the surgery. So that's why we actually try to identify the sweet spot by giving the real-time current. And we check with different pulse width, different frequencies. So for tremor dominant patients, we use high frequency. High frequency is known to stop the tremors at that same point. And if the patient is having dystonia, high pulse width helps in improving the dystonia. If the patient is having freezing of gait, low frequency helps in improving the freezing of gait. Same point, same current, but yes, just by changing the frequency or pulse width, you can alter or control different symptoms. So that's the beauty of the neuroelectrophysiology. Now, like this lady, she's trying to assess her both hand movements. So I think stuck.
अभी improvement कितना अच्छा है?
1 minute, I'll try to show you. She's trying to assess. We have inserted on the left side of the brain. So our right hand movements are smooth, but left hand movements are not smooth.
1 milliampere
Left hand is still rigid.
4 milliampere चल रहा है? नहीं बंद है सब.
So patient themselves can assess, and they can, if the patient is good, intelligent or young, they give us very good feedback. Because many of the things we don't realize as an external that which one is program 1 is good or program 2 is good. But as a patient, they feel that yes, there is some resistance in this which we will not be able to appreciate externally.
अभी improvement कितना अच्छा है?
बहुत अच्छा है अभी तो अच्छा ही
So this guy is also 55-year-old.
So DBS is effective?
yeah for me it is effective
He's able to give us good feedback that how much is the improvement. He is able to tell us in percentage, and how was his experience also is sharing.
Increase कर current. Nice smooth movement.
So all these movements, like this patient, before the DBS, he was not able to walk. He was having a lot of freezing of gait. So from one room to another room, he takes 3 minutes. So he used different tricks, maneuvers to get rid of that freezing. So his legs get stuck to the ground. So in these patients, we have to use low frequency. So you put low frequency, the freezing improves. But if you put high frequency, the freezing gets worse. They can't walk. They will not be able to get up from the chair. Same patient, immediately after surgery, you see him how he's walking normally. Nobody will say that he's having Parkinson now. So that's the beauty of the neuroelectrophysiology. Without damaging any brain structure, just by modulating the circuit, you get this result.
Yeah, with the right hand.
So this man who was having tremors, in tremors we have to use high frequency. Same contact point, but high frequency. So immediately the tremor stops. And now this is so instant that you can reverse back. You turn it off, you turn off the device, they will get back their tremors. So like this. So he's a pediatrician from Pune. We operated and we turned off his device now. He's having tremors, good tremors, grade 4. Now I'm turning on his device with the tablet, the programmer. Now the DBS device is on and his tremor stops. Now we again turn it off, tremors will restart. Tremor restarts. We also give remote to the patient, remote control, where patient can actually titrate the current according to our advice, because every time they can't come to the hospital for all the program settings. So we give them the remote, and with the remote they can increase or reduce the current. Sometimes they are traveling, they are outside, so they say suddenly my tremors are coming, or I am freezed, I am not able to walk, I am at airport, I am not able to walk. So we just ask them to do some settings with the help of the remote, and they are able to walk within seconds. Like this is just an example to show how the remote is useful. Like this lady, you can see the tremors in the hand. Now the stimulation is off. Now I'm turning on the stimulation with the help of the remote. And the tremor stops. So it just takes few seconds to stop it. Or if they want to experience the Parkinson's disease again, they can go back, experience and come back. So this lady from Yemen, we operated. She was not able to walk. She required 2 people support to walk. She was having dystonic tremors. She's mother of 3 kids. Husband left her because of Parkinson, and brother brought to India for the treatment. So we did DBS straight away. And immediately after DBS, you see her how she is walking without any support. Body is completely free. Now no one will say that she is having Parkinson's. She has got that catwalk back. Even the speech improves, the voice improves with the help of the therapy. So speech area is little dorsal to the subthalamic nucleus. So we always, whenever the patient we get with speech affected, we try to target the dorsal part of the nucleus. So dorsal part has all the speech fibers. This patient sends me video after 2 months saying that I am singing a song. Today morning also, one of the patient's husband has sent me an audio clip of wife singing the song. So even the voice improves. So subthalamic nucleus is actually divided into 3 segments: limbic, associative, motor. It's not the concrete division like India-Pakistan boundary, but there are majority of the motor neurons are on the posterolateral part, and majority of the limbic neurons are on the anterior and ventral part, and the associative fibers are distributed in the center. So you might stimulate sometimes whenever you are still, if you are in the motor part, you can still activate the limbic neurons. And if you activate the limbic neurons, there will be behavior side effects. Patient might feel depressed, patient might sometimes become maniac, he might jump out of the running car, he might take out the gun and shoot someone. So all these things can happen. So these are all events have happened with us, with our patients. There was one policeman who has done encounters, and he started telling those encounters to everyone, which has to be kept secret, but he started telling everyone. He didn't realize that it should not be told to anyone. And he had a gun, he took his gun to the village and started shooting there. So all these things can happen. So we have to be very aware that what we are stimulating, you can completely transform the person. So the beauty now with the current devices are that these electrodes, we can actually steer the current in a specific direction. These are segmented electrodes. So you can actually, like the contact 6 current is, this contact 6 current is spreading to the internal capsule. I guess you all are aware of internal capsule, right? Internal capsule fibers deals with the motor fibers. So these fibers are getting activated and actually were causing side effects, that he was getting pulling of the leg and hand. So what I did is, I stopped this contact 6 and I gave current only to contact 7 and 5. So the current is spread only to the subthalamic nucleus, not to the internal capsule fibers. So you can steer the current also. You can direct the current. You can give current only 90 degrees, and remaining 270 degrees you can block it. So that is the latest technology. We can also sense it with the help of electrodes. You can record the beta bands. So this one patient who came to me with problem in the gait and difficulty in walking, and also they had behavior issues. So when I did the imaging, I have reconstructed the image, MRI and CT scan. on my software, and I found that one lead is outside the nucleus. It is not at all in the target. So that outside the nucleus, I don't know what fibers it is stimulating. So I have reconstructed all the fiber tracts, and I found what exactly is happening. So I have reconstructed the neighboring fiber tracts with the help of the DTI imaging, and I looked this electrode actually what it is causing, where it is, and what fibers are getting activated. And this is exactly in the nucleus, in the dorsolateral part, but this is outside. So that's why that patient actually was not able to walk properly, and also I was having behavior side effects. So all this neuroimaging we do, we reconstruct the fiber tracts, and we see which fiber tracts are getting activated, how much distance my electrode has to actually deliver the current, where is my sweet spot, how much far it is. Then I calculate how much current needs to be given to that area. So this patient has developed maniac behavior changes.
Okay. Don't worry.
He started as soon as we turned on the device, he said, I am trying to kill him. This is the leg fibers getting.
Do you know?
Do you know? Here is leg.
I am governor.
Stimulation. So immediately we change the settings. So we actually, the ring configuration of the current we changed, we avoided the anterior part of the nucleus, which actually carries the limbic neurons. So as soon as we did that, his
problem
he
is
became calm, silent,
I mentioned please
gone.
considered by themselves
3-4 seconds, everything changed.
for a period of 30 years tomorrow.
So all this
And
happened
from
with DBS. This is the next day morning. He was all right. There were no further changes. He was actually apologizing that I behaved rudely and I was not in control. I don't know what I was doing, but I remember everything what I have done. This guy also he was having difficulty in walking.
Slowly walk.
Because of the wrong fiber tracts getting activated. So he was having the freezing of gait. So this was his gait, and then after we reconfigured the settings, he was able to walk normally. He was able to control his gait. Wherever we asked him to stop, he was able to stop. So coming to the chorea is also another type of disorder. So here it's called as rubberman gait. The body swings a lot. And even the patients are not able to eat, they can't sit. So this is also a movement disorder called chorea. It happens in neuroacanthocytosis, it happens in Huntington's. So we used globus pallidus internus as the target, and after 2 months of the surgery, he was able to walk normally. He was able to sit erect, and he was able to eat. So we can transform lives with this electrophysiology treatment. Then coming to the writer's cramp, which I mentioned earlier, difficulty in writing, only in handwriting gets affected. There's a severe pain in the wrist. The wrist gets twisted. Similarly, if there is a software professional, they will develop a problem only in typing. So this man has typing problem, either it is a mobile or the laptop. He has difficulty. So whenever he is using the right thumb, he is not able to appropriately type the keys.
Something which stuck, sir.
And it goes into spasm. Only while operating mobile and laptop. That's all. Otherwise, writing is good. Rest all work he can do normally. So we did DBS and we did thalamotomy actually. This is a lesioning surgery. It's a very simple surgery, daycare surgery. And during the surgery, we assess the functions which are affected, the same functions we make them do during the surgery. So we bring their laptop, we bring their mouse, we bring the spoon. So whichever tasks were difficult for them to do or they were having pain, we perform during the surgery, and they assess whether they have got improvement or not. So we create the lesion. So we increase the size of the lesion depending upon the results, but we have to be very careful. If we over lesion it or increase the size of the lesion, we can actually damage the motor fibers and we can create permanent side effects also.
Hand movements are improved.
So it has to be monitored properly and done well.
Yes. You stop. Okay.
And after the surgery, he was able to walk, or he was able to write normally. There was no pain in the hand or no twisting in the hand.
Hello, my name is Deshpande.
Then this is the generalized dystonia. Neck dystonia. This is the field. This is the electrical field in the fiber. And we are activating all those fibers in the nucleus through the field of internet. And after that, within 2 months, they develop correct posture. The dystonia gradually improves. So this is blepharospasm, inability to keep the eyes open, and also they develop difficulty in swallowing and difficulty in breathing. He's a physiotherapist, not able to do the practice. So severe blepharospasm. He can't drive. He can't attend the patients. He can't breathe. He can't eat. So much of difficulty he has. So this also we treated with globus pallidus internus activation, and after the surgery his blepharospasm has reduced and he was able to open his eyes, he was able to talk, You're doing good now. he was able to eat, the spasm while breathing has disappeared. So all those dystonia completely disappeared with globus pallidus internus stimulation. So neuromodulation can be used for various disorders, like for obesity, for anorexia, for addiction, for depression, for Huntington's chorea, OCD. So all these disorders can be actually controlled with the neuromodulation surgeries, with deep brain stimulation surgeries or lesioning surgeries. So there are so many areas to explore where you can actually utilize your neuroelectrophysiology knowledge and actually explore more that how it works, and we can more fine tune on this. There are so many areas where we can work together. Like for pain also we use thalamic pain syndrome, neuropathic pain. We do spinal cord stimulation. So we use the spinal cord stimulator for the spine, for the pain in the legs or chronic back pain or the oncogenic pain. These are the electrodes have been inserted into the spinal cord. So they actually inhibit the pain pathways which are going to the brain. So the pain pathways are suppressed. So the brain doesn't perceive any pain. So whatever the pain is there in the legs or in the back, they don't feel. You don't have to give them any drugs, any narcotics or no NSAIDs. Completely they will be pain free for the entire life. For intractable epilepsy also we control the seizures with the help of the DBS. We insert into the anterior thalamic nucleus. Then we also do for the patients who are on ventilator dependent, who are not able to breathe because of spinal cord injury for long term. So we do phrenic nerve stimulation. We place the electrodes on the phrenic nerve, which controls the diaphragm movement, and that helps in the respiration. So that the first case we have done in the Maharashtra. In India till now only 3 cases have been done. 1.5. So we activate the phrenic nerve. This is the OT, and we are stimulating the phrenic nerve in the neck, and once identified we permanently implant the electrode there, and gradually the patient is weaned off the ventilator and is breathing on his own, and the patient is wheeled out of the ICU. You're fine? Similarly for urinary incontinence, erectile dysfunction, we can do sacral nerve stimulation, which helps in the bladder control, bowel control. The sacral fibers gets activated and the bladder tone improves. We also do for the psychiatric conditions, OCD, depression, Tourette. So we have this neuromodulation department in the Wokhad Hospital. We have formed the complete department there, and especially all these types of surgeries we are performing. And we are also involved in a lot of research areas. So if anyone is interested, they can contact and we can collaborate. Thank you so much.
So since we are running low on time, we'll just take one pressing questions. Others can interact with Dr. Baldia during the tea break.
That was a wonderful talk.
Thank you.
And I have questions even for every slide, but I'll be very quick. So regarding your DBS stimulation, how frequently do you give that stimulation to the patient? And when you hand over them the remote.
It is
So
continuous stimulation, madam.
it's continuous stimulation?
Continuous.
Okay. And
24
when
into
you-
7.
Okay. So similarly, when you hand over them the remote control? it's
Remote
the same?
control is only to troubleshoot because we are not curing the disease. The disease progresses.
Mhm.
So after 3-4 months, the disease progresses. So when the disease progresses, the amount of current what we are giving is inadequate. So at that time, they need to increase it, or sometimes they have to lower it. So whenever they have problem to troubleshoot, so they don't have to come to the hospital. They can just make a call, and then over the phone call, they can just manipulate it.
Okay.
That's why.
Thank you so much.
Yeah.
Okay.
Thank you, Dr. Baldia, for that dynamic and enlightening talk. Your insights on neuromodulation and translation neuroscience have broadened our understanding of clinical to laboratory insights. We now request the moderator of the session, Dr. Soumya Pati, to kindly honor the speaker with the token of her respect. Thank you, ma'am. We will now pause for a 15-minute tea break. We request all our esteemed speakers, faculty members, and the participants to join us for refreshments and reconvene shortly. We will now resume at 11:40 sharp. Thank you.
बंद करवा दूं, बंद करवा दें?
Yes, sir. सर एसी ना कमी करवा दीजिए.
I use this mic, no?
Yes, sir. So you can use this mic or either that one.
No, I don't comfortable with this now.
Okay, okay, sir.
थोड़ा सा पास ही रहना पड़ेगा.
पास ही रहना चाहिए, ठीक है. इसको खोल दीजिए.
मैंने कहा था
आपने सेव कर लिया? आपने सेव कर लिया इसको डिवाइस में?
ये मैंने कहा था.
Sir, please have mic.
I only have key. Okay, go.
एक मैं आपको दे रहा हूँ, एक मैं लगा रखा हूँ अंदर, एक और प्रोग्राम उधर चल रहा है ना इसमें बगल में। कहाँ पे 2 लगाए थे? पहले पहले हाँ, पहले मेरी बात सुनो। आपने 2 लगाया था, वो रुको मैं बता रहा हूँ। एक हमने खा लिया, मतलब फिर मैं चला गया था, आप ही लास्ट में वाइंड अप किए थे ना? पहले दिन आप ही थे, तब नहीं। हाँ, क्योंकि मेरे पास 2 कैप्चर कार्ड हैं जो अभी प्रेजेंट टाइम है। अरे मैं देख लिया अपने बैग में, अपने बैग में फिट है। मुझे कुछ चेक करना था। सर आएंगे, उनको ये देना है। इधर आ, इधर आ, बैग में।
Welcome back, everyone. Let's keep the momentum going. We now continue the morning session with our next distinguished speaker, Professor Anirban Basu. Professor Basu is a senior neuroscientist at the National Brain Research Center, Manesar. He completed his pre-doctoral studies at the School of Life Sciences, Visvabharati University, Santiniketan, his doctoral research at the Indian Institute of Chemical Biology, Kolkata, and his postdoctoral work at the Pennsylvania State University College of Medicine, USA. Since joining NBRC in 2004, Professor Basu has focused on understanding how neurotropic viruses alter brain development and function, leading to neuroinflammation and neurodegeneration. His research has been pivotal in revealing how the neuroimmune system governs viral infection within the brain, bridging the gap between basic and translational neuroscience. Professor Basu has been honored with numerous accolades, including National Bioscience Award for Career Development by Department of Biotechnology, Government of India, Tata Innovation Fellowship, Basanti Devi Amirchand Prize by ICMR, and Dr. J.C. Bose Fellowship, among many others. He's also the elected fellow of all the national academies. We are honored to have you here with us today, sir. We now invite Professor Basu to deliver his talk titled The Gut-Brain Axis in Disease and Aging, Lessons from Viral Encephalitis and Indian Nutrition.
Okay, am I audible from the back? Okay, no problem. So, good morning all of you, and special thanks to Rachna and Professor Malik and all my colleagues from this department that invited me for this occasion. So what I will do for next 35 to 40 minutes to tell some of the work we are going in the lab, and particularly my lab is primarily interested in viral encephalitis. If a virus infects your brain, what actually happens? But in last 4 to 5 years, we also start working with the gut-brain axis, because if you know, there is a immense literature evolved in last few years to understand the gut-brain axis. Why gut-brain axis is so important?
ऑनलाइन जा रहा, लाइव भी जा रहा
है,
ऑनलाइन लाइव जा रहा है, माइक से बोलना पड़ेगा तो यहाँ से.
Okay, fine. You don't have collar mic, no? Okay, fine. So, why gut-brain axis getting so important, that I will tell in my talk, in the later part of my talk. And there is, of course, some part of the science which I will discuss in my talk in the first part, but later I will move to some general messages what I want to give at the end of the talk. Because as you see, I will try to cover many things, from viral encephalitis to Indian nutrition and aging. So I'll try to connect all of those things together. So I'll start with this question: how many of you know actually that gut health could be the key to treating brain disorders? I never thought that our gut could be connected to the brain. But now, with some current literature, particularly from this review by John Crean's group from the APC microbiome, that almost all the brain disorders, which not, restricted to say Alzheimer, autism, Parkinson's disease, schizophrenia, depression, they are some way or other involved with the health of your gut. So at the end of the day, what you are eating is very important. you think twice before start eating. That's my first message. This is the general outline of my talk, but I will go some of them more detail, some of them in a more maybe in a not so detail. Like introduction to gut-brain axis, the mechanism of communication between gut, brain and immune system, the role of gut microbiota in immune regulation and brain health, how disruption in this axis contribute to disease, that's very important. As you see, our daily habits, our lifestyle, our food habit, good enough for this, आपका technology इतना अच्छा नहीं है थोड़ा बहुत, हाँ, ठीक है, so anyway, never know, huh? Hand mic, I don't, fine. Is this hand mic? Is it on? Okay, so as you can see that your gut health disruption may be critical for many diseases, not only brain disorders or all your metabolic disorders, so what currently India is facing actually. And then of course we will talk about the ultra processed food and gut dysbiosis. Recently ICMR came with a very strong guidelines and food habit and the nutrition in this country in general. And lastly, I will touch little bit about aging and gut health. That's the most provocative part of my talk. Last few slides I will talk how aging is connected with the gut health. Now if you see here that your 20%, 20,000 the human is only 1%. We are very concerned about this 1% of our gene, but our 99% gene actually consists of our microbes. In this slide, if you see carefully, when we born, we have very low diversity of microbiomes, and we developed many disorders like anxiety, autism, and many neurodevelopmental disorders. And that is the point, we have a very low diversity of microbes. When we are adult, we have many high diversity of microbes, many microbes we have. But if you see, in general, adult stage, you have less brain disorders, particularly neurodegenerative disorders. Then again we have neurodegenerative disorders in the later stage of our life when you have a very low diversity of microbes. So there is a direct connection between your diversity of microbes and most of the brain disorders, including developmental disorders. In recent past, in last 40 years, there is a tremendous amount of C-section delivery increased across the world. So when you have a normal delivery, your offspring get more microbiome from mother. But when you do the C-section, your offspring get less microbiome from mother and more from environment. So if that is the cause of the more developmental disorder what we have seen today, is it the cause? So recently there are multiple studies done in the Amazonian rainforest. Amazonian rainforest, there are certain tribes, they are not exposed to the so-called modern civilization. So they still do their 100% delivery is a normal delivery. There is no C-section there. And these kids, they don't have any neurodevelopmental disorder at all. They may die in infectious disease in that some point. But when they're born, it has been carefully tested that they don't have any developmental disorders. But again, they have a 100% delivery through vagina. There is no C-section, right? And this is very well documented in many papers that C-section, you get more microbes from the outside. That's whole reason first 6 months breastfeeding is so important, because your microbes goes from mother to offspring. Now, what is actually gut feeling? We always say gut feeling. gut feeling is nothing but a gut and microbiome signals to the defined receptors. There is a vagus nerve. Vagus nerve is a connection between your gut and your brain. And vagus nerve has many receptors. Through this receptor, it goes to the insular cortex, and insular cortex ultimately process and integrated to the brain. Of course, all of you heard about the serotonin. What serotonin does? Serotonin is a hormone, but do you know that most of our serotonin actually produced in gut, not in the brain? Why gut makes 95% of your serotonin, not the brain? Still we do not know, because serotonin which made in the gut actually doesn't cross the blood-brain barrier. It's a big molecule. But vagus nerve has many receptors for serotonin. Okay? And we know that depression, one of the first choice of drug is serotonin receptor uptake inhibitor, which is a common choice of drug for the psychiatrist will prescribe. But serotonin doesn't produce in the brain. Major, only 5%, 95% serotonin comes from your gut. Now there's a direct connection between your microbiome, this immune loop, and the brain. And what people are now start thinking that understanding the gut-brain immune axis may lead to microbiome-based precision biotherapeutics for inflammation-driven and metabolic disorders. Because your gut microbiome is very different from my gut microbiome. And your gut microbiome is very different from her gut microbiome. So if we want to design a precision biotherapeutics, understanding a gut microbiome is extremely important. So I'll little bit move to the general innate immune response in the brain. So if you see the brain, the most immune response cell which can do is the microglial cells. Microglia can activate, proliferate, and release defined cytokine chemokines. And defined chemokines makes it more vascular permeability. And finally, it can release the product like TNF-alpha, nitric oxide, reactive oxygen species that can kill the neuron. And so you get the neuronal death. So that's the basic mechanism of the innate immune response in the brain. Now the disease we are working in the lab for many years is the viral encephalitis, which is Japanese encephalitis. That's a major focus of our lab. And this is the RNA virus. And if you see people, 3 billion people live in this area. And virus of course can move from one part of the another part of the world very easily for the travel, through travel and other means and due to climate change. So this virus belongs to the family Flaviridae, the same virus of Zika, dengue, West Nile. And virus is spread by mosquitoes, and it's a neurotropic virus having a positive sense single-stranded RNA genome. Now, what happened in this disease, what we are working for many years now, that following the infection, neuron get dying, and due to this neuron death, microglial cell get activated because you need a phagocytic cell to clear that dead cell debris. So microglia get activated, and they start releasing different cytokine chemokine, and phagocytosis happen. So you get the dead neuron due to the viral infections, and some neuron again dying due to this cytokine and chemokine. So basically there are bystander death. Both way you get the neuronal death. That's typically very, I would say, simplistic cartoon to see what happened in this viral infection. Now, a few years back, maybe 2018-19, we have seen the literature that gut microbiome metabolite is important, which regulate the neuroinflammation. So that we have seen around 2018-19 with this literature, and that point we start working in this idea that how this metabolite do when we treat the cells and following in after that we give the infection. So in this viral infection model where we see the major neuroinflammation, does this metabolite has any role to play? So major metabolites which we start working is the acetate, butyrate, and propionate that actually generated from the food like complex carbohydrate in our gut. This short chain fatty acid, that three of the metabolites I mentioned, that acetate, butyrate, and these three of them. So one of the most important things that the short chain fatty acid does, they actually reduce microglial activation and neuroinflammation. So that's our initial thought, that to make this hypothesis that maybe they can be effective if you to reduce the neuroinflammation, what you can see in the viral infection. Now my student, postdoc Atri, and the PhD student Indira start working with this idea. If we use this short chain fatty acid cocktail with three of these metabolites, and are they able to reduce the neuroinflammation in general following viral infection? So first experiment what Atri did, Atri treated these cells with this short chain fatty acid and then bring the virus. And what we have seen, there is a significant reduction of the pro-inflammatory cytokine like TNF, MCP1, IL-6 following this pre-treatment with short chain fatty acid. So in vitro situation, short chain fatty acid certainly play a role in reducing the inflammation in the microglial cells. And then we did a sequencing to find out the microRNA, because microRNA, earlier our work showed that microRNA also is important to regulating neuroinflammation. Some of the work when Yogita was there at NBRC, we published together that microRNA plays very important role in regulating neuroinflammation following viral infections. So one of the microRNA we have identified that MIR20013P, they are very important in regulating this inflammation process in microglial cells. And we did all the general work we did for the to identify microRNA and its target. We have identified that the ZBTB20 is the target for this microRNA. And following that, we also showed all the target analysis, downstream target analysis we did. But the most important findings from this work is that short chain fatty acid abrogate JE virus induced inflammation in microglial cells via this microRNA. So definitely from this work we concluded that at least in vitro situation, this short chain fatty acid cocktail capable of reducing the neuroinflammation following viral infection. Then my student Indira moved to a in vivo animal model. There also she has pre-treated this animal with short chain fatty acid, then bring back the virus, and we wait for different time point like 5 days, 7 days, and 10 days. So there she also identified that most importantly what happened, that when you see the symptom progression, the group which got the short chain fatty acid pre-treatment, they are far better off than a group which got the virus, alone virus, not short chain fatty acid. And their weight also restored significantly. And their behavior also, there is improved, is a hind limb clasping behavior. The group which got the short chain fatty acid, they have significantly showed the improvement. And most importantly, they didn't survive many more days, but at least few days more. So there is a delayed death we have noticed when you treat the animal with short chain fatty acid. And probably the reason is that here also in the animal model we have seen there is a significant down regulation of different cytokine and chemokine, pro-inflammatory cytokine, chemokine, which are important in the neuroinflammatory process. So you can see here the MCP1 and TNF and IP10, IL-1 beta, IL-6, all their level are significantly down regulated when the group got the short chain fatty acid pre-treatment. Again, this is the protein level, that previous one, the mRNA level, to show that there is a significant down regulation of the chemokine and significant down regulation of the different cytokines. Also, the level of IBA1, which is a marker for microglial activation, is significantly reduced, and the level of phosphorylated kappa B also significantly reduced. So that's the hallmark of the inflammation, which short chain fatty acid able to reduce significantly when you treat the animal beforehand. And this is the microgliosis. You can see very high activation of the microglial cell here in the group which is alone virus. And when the short chain fatty acid treatment happened, you see microgliosis are very significantly reduced. So that clearly shows that short chain fatty acid able to down regulate the microglial activation in general. We have also seen the astrogliosis here by marker, so clearly show the highly about the astrogliosis here that also significantly reduced when you treated them with the short chain fatty acid, this animal. So our conclusion here is that short chain fatty acid treatment prolong the survival in JE infected mouse, and short chain fatty acid admission significantly reduce the microglial activation post JEV infection. So I have showed you in the in vitro microglial cell, then I moved to animal work, and animal also we have significantly showed that if you treat it with the short chain fatty acid cocktail, you see the significant down regulation of microglial activation and neuroinflammation. Now, what my student Anirudh start working, he wants to see what actually happened with the gut microbiome in general. So we infect the animal, then we start sequencing for this animal to see the actually what type of microbes we can see following the infections, and he exactly did with that full symptom and JV post and 5 day post infection and full symptom, and take this colon with the fecal matter inside and send it for the 16S RNA sequencing. What interestingly we found here that this firmicutes, these bacteria's level significantly down regulate, and these bacteria, these proteobacteria here, they are up regulated. So that's some changes we have seen in this microbiome in general. And generally in the normal situation, you see the firmicutes and bacteria, their ratio should be 1:1 kind of, and that also change here. But it's not moving also. Slide is not moving actually. No, slide is not moving.
Maybe battery has gone. You can
No, slide is not moving actually.
Oh, hang ho gaya.
I think you can just shut down and then start.
This is connected to live streaming also, so we don't know. This is not our laptop, the university's only.
So hang हो गया.
हाँ, ये पॉइंटर तो काम कर रहा है. Okay, Anirudh, pointer is working. This battery is new.
It's moving now. Okay, fine. Thank you. So what I was discussing that we start observing the fact that there is a severe gut dysbiosis happen due to the infection. As you can see here, this normally should be like this two bacteria. These two group is like a 1:1. Now you can see the ratio has been changed. Now, also we seen the changes in some of the lactobacillus group. Lactobacillus is good for your system, GI tract, but their number has been reduced. And some of the bacteria which is not so good, like Escherichia and Shigella, their number increased. And this is the point we have figured out that why we see chronic dysentery in these animals for so many times. And also when we done a clinical trial for another study in KGMU Lucknow, my collaborator from there, KGMU, she also mentioned to me that patients are getting this dysentery when you can see the JE infections. But that only one of the reason. Now we know that there is an increase in the Escherichia shigella, those pieces in the colon following the infections. And see, there are some changes we have seen in the colon structures. What is a very recently done actually with these studies. What interestingly we have noticed here that this fecal pellet count also reduced following the infections, and the colon structure also changed significantly following the infected animal group. So what is our conclusion here? That reduced colon length and morphological change of colon and small intestine we have noticed also. And if you see here that there is a abnormal colonic mucosal production also noticed in the group which is following the JV infection. And when you see the ultrastructure, you can see in the control group the structure is much more prominent, which is kind of distorted in the infected group. So that's the ongoing study in our lab. So we concluded that there is a major change in the colon also noticed in this infection process. And our conclusion from this part is that reduction in this firmicutes and bacteriota ratio, lactobacillus sp abundance was declined upon infection, a trend in increasing abundance of this Escherichia and Shigella, and abnormality in the GI tract following the infection. That we have noticed from these ongoing studies. Now I'll move to the much more general part of my talk, which I started in my initial beginning. I have mentioned that. So now gut microbiome, what is the importance of this gut microbiome in general? If you see, this gut dysbiosis can happen for many reasons. Of course, I mean, antibiotics is one of the reasons, and we don't have much choice on that. And then also environmental stress and other genetical reasons is there, but lifestyle and diet may also play a very important role in our gut health and gut dysbiosis in general. And if you see here that gut dysbiosis and metabolic disorder are very connected very closely, and it's a both-way process. You may have some of the disease and there you may get the gut dysbiosis, or you get the gut dysbiosis and that may incline towards some of the disease. Now we have the recent hypothesis or the result, if you see the experiment across the world, that of course those diseases are the metabolic disorder. We know that type 2 diabetes, non-alcoholic fatty liver disease, maybe colon cancer also, cardiovascular disease, but now we start believing that many of these diseases also directly connected with some of the metabolic component. Like if you see the recent school of thoughts that even some of the cancer we start believing they are also a metabolic disorder. Now you see the recent ICMR report. ICMR is telling that almost 60% of the disease what you see in this country actually from your food. This ICMR report from last May 2024. This number is a big number, maybe it's a more, I do not know. But maybe, and there are many diseases which actually comes from what we actually eat actually. And ICMR published almost 120 pages guidelines about the dietary habit. And one of the things what this Times of India this study showed that is Indian diet protein deficient? Because if you see, they did this study in the 6 different cities across the country, Lucknow, Ahmedabad, Mumbai, Vijayawada, Chennai and Kolkata. All these cities foods are protein deficient, and this is the thing, is the urban population, the urban rich population who actually can afford to have a proper balanced diet, whatever we can consider. But there is a major deficient, and I believe if you do another study, you may get the number here and there, but that's the overall broad idea this recent study actually showed from Times of India, this study group. And there are many reasons what people showed, that some people strongly believe from fruits they can get enough protein and etc. There are many things the study came up actually. And some of the lactating mother and would-be mother, they are also taking this protein deficient food. Across the country they have found from these studies. Now what ICMR suggested that there are many problems in our food, of course, ultra-processed food and often high fat, sugar, salt, regular consumption of this ultra-processed food, high fat, sugar are known to increase the risk of many non-communicable diseases like diabetes, hypertension, cardiovascular disease. And ultra-processed foods are usually high in fat, sugar, salt, and in low in micronutrients and fiber, and mostly calorie dense. Restrict consumption of high fat, and ultra-processed food source that suggest for that. Always prefer some of the fresh and minimally processed food, whole grains such as millets and those things. So now question is that, of course, we have identified that sugar is one of the major problem in this all the foods. And excessive sugar consumption is linked to numerous health problem and most of the metabolic disorders. And some reason our entire country's food is loaded with sugar. If you know I'm sure all of you know the basic 101 of biochemistry. If you go to the 101 biochemistry, your laddu is not sugar, your rice is also sugar. And that's the fact. It's not that you take rice, you are not taking sugar. It's not the case. If you know the basic biochemistry, 101 biochemistry, your rice is sugar, your chapati is sugar, your millet halwa is also sugar. And your laddu is of course sugar. And sugar is an addiction. Like you have an addiction of any drug, normal, any drug, what do we know? Because if you take sugar, its craving increased. And this craving will never go. It's a vicious cycle. And if you say it goes on. You like it, crave it, then take more sugar, your insulin secretion happen. Then again you start craving and you go on and go for. This is a vicious cycle. And it's again, it's an addiction. But one thing I will ask you, all of you, when you see this sugar, do you like to eat that sugar? Probably none of you. Then what happened when you see this? What's wrong that time? Wrong, I won't say wrong. Then what changes happen in the brain then? I don't think we don't like to eat this, but when we come in this front of this case, then what will happen to us? Right? So there's something happen, and this is a craving, and this is the addiction. And now you see, this is a healthy cereal, selling by Kellogg's, these multinational companies across the world. And what you are having here, if you start reading this fine print here added sugar, I am not talking about natural sugar, added sugar is this much. If you take all 30 days of your month, you are taking 600 grams of sugar from this so-called healthy breakfast. Understand the problem? And money goes to Kellogg, and a multinational company, American company. So breakfast cereals often added sugar to enhance taste and make the product more appealing to consumers. Why? Otherwise people won't find it taste. Your palate don't like it. Your palate like the taste. And that's why most people think if you don't give them sugar here, they will find it bland, and they avoid buying this company's cereal. Okay? So, and sugar acts as a flavor enhancer. But at the end of the day, you are taking 600 grams of sugar without no reason every month, and 7 kg of sugar per year for taking this so-called very healthy breakfast, right? Now come to one of the most favorite health drink of this country. So this is a marketing strategy, of course, to boost your sales, as sugar can be addictive and encourage repeat purchases. So this is the most favorite healthy drink of this country. Let's see what it is there. So here the added sugar is this much per 100 gram. I mean, this company, they are not doing anything wrong. They are written there. If you go to the code, you can't get anything out of them. They are declared this one. And so if the 20 gram is the serving size, so if a kid can take 40 gram per day two times a day, that means per day 12.88 gram of sugar. In a month, almost 400 gram of sugar. So I appreciate those kids who refuse to take Bonvita. They are smarter. So how to restore gut balance? I will say, if you ask me one thing, I would say stop sugar. There are many other things. Antibiotic you cannot probably stop. If you have a accident, if you have a surgery, you have to take antibiotic. If you have a fever, cold and cough, and there is no choice probably. But you can definitely stop your sugar. That will actually make your gut microbe feeling them good. There are many studies done so far which clearly show if you take sugar, some of the bad gut microbiota actually increased and other decreased. So last part and the most provocative part of my talk, why we age. Do we have to age? So I don't know how many of you read this book. If you do not read yet, please read it. Why we age and why we don't have to. This David Sinclair has a big lab at MIT and both in Australia. I think this book has many things. There are molecules. I am giving you an example. There is a molecule called sirtuin. If you overexpress sirtuin in a yeast or in a mice, they live longer. You know that. This study is done across the world. And there are many things that which actually can stop your work or revert I do not say, that's again more provocative statement, but at least stop your age for some years. This was in the yeast. I'm sure there are many studies going on the human level also. Now, one thing David Sinclair mentioned about your microbes there. People generally who live longer, but also of course another thing is the healthy aging. Of course, all of us will age, but people who age comparatively healthy, their microbes have something different microbes. It's not like so your microbes also changing. If you remember my first slide, your microbial diversity is very less when you are aging, that I showed in our first slide, which was in the beginning of your life, you have less microbial diversity. When you age, you have less microbial diversity. But people who actually have a healthy aging, their microbes actually looks like a more younger people's microbes. And this is my last slide. This study published in the Cell Reports Medicine, a Spanish woman who lived 117 years. And apparently, clinically, she was very in good health, right? So they did, this single paper published in this only one person. What they have found here, she has many features, and she passed away. They started the study in 2021, they complete the study 2024, and interestingly, she passed away that year itself, and they published this paper in this year, early this year. And when she passed, her recorded age was 117 years, right? So many things, she has like a younger features, and some of course aging features. One of the younger features is that her microbiome. Her microbiome biologically is very similar to a younger people. Then this group of researchers, they asked her, what you eat? Normal question, because your microbiome is very younger, looks like. She said, whatever I eat in a day doesn't matter, but I eat 3 times yogurt in a day, okay? And I believe, and I think it's true, that a Spanish countryside yogurt quality is far better than your Amul or Milky Mist. They are local in the farm, they are in the outskirt of Spain somewhere she was living. So their yogurt quality probably definitely good. And she said, if I miss all of my meal, I don't care, but I have to eat 3 times yogurt in a day. But of course, she has a lot of other features of the younger, like a favorable cardiometabolic profile, low-grade inflammation, those all are important. But I just want to point out these things because I want to connect your talk today with the aging and the gut microbiome. So that's it. That's my last slide, and I will end my talk with this question: does aging drive changes in the gut microbiome, or do shifts in the gut microbiome actively modulate the pace and quality of aging? So it's a both way possible. We really do not know. Does, as we aging, our gut microbiome changes, or our gut microbiome changes, or we are also getting aged. So that's one possible. I'll end up my talk. Thank you so much again. And this is my institute. Thank you.
The forum is now open for discussion.
Hello, sir. Very interesting talk. So my first question is that what about those people in Japan who actually consume a lot of fish and they have a healthy aging? And second question is that, can I say that people who age in a very slow manner, will they have, is it correct to say that they basically can have high levels of HDL as compared to LDL? Does it make sense?
Well, HDL, LDL, of course, my high HDL, of course, is definitely good, but aging, how much is connected to the LDL, that I really do not know, frankly speaking. But Japan, as you said, Japan, they have studied, they also have a very healthy microbiome in general. Because Japan, those people may generally take the seaweed and mostly those type of things. And Japan, I think, population, aging population, they are generally healthy population, apparently. But I do not know the study done, but I think there are some studies done in Japan also.
So do you have any comment on gut microbiome, brain axis, gut-brain axis through this?
I started with that.
With that, yeah. So if you can just summarize through that, that will help probably.
So apparently, if you see all the work done by this John Crean and his group from this APC, that University of Cork, that they now have a very distinct evidence that even some of the psychiatric disorders, they have a direct connections with the gut-brain axis. And they have many clinical trials, cohort-based studies going on in Europe that clearly showed that there is a direct connection between gut-brain axis and the many diseases actually.
Is it through Vegas or it is through
Right. See, Vegas, of course, Vegas has a many receptor for serotonin. As I mentioned in my talk, that why gut makes 95% of body serotonin, nobody knows. Our brain only makes 5% serotonin. Gut makes 95% serotonin. But there are many receptors of serotonin in the vagus nerve. But interestingly, this serotonin doesn't go to the brain because their size is bigger and blood-brain barrier is there. But what these serotonin are doing in the gut, that nobody knows. But there are receptors of serotonin in the vagus nerve.
Thank you, sir, for your thought-provoking lecture. Your work provides remarkable insights into the interplay of infection, immunity, and nutrition in neurological health. We now request the moderator of the session, Dr. Amrita Pathak, to kindly honor the speaker with the token of our respect. Thank you, ma'am. We will now break for lunch. We request all our speakers, faculty members, and participants to proceed for lunch. We will resume the session at 1:20 p.m. sharp. We request everybody to be here on time to the session timely. Thank you.
ऐसे सर अभी इनका ब्रेक हुआ है ना अपन एम डी
ऐसे 2 मिनट रन हो रहा है ना वो आप मुझे दे दीजिए मैं लिखवा दूंगी थैंक यू Participants are seated this side. Welcome back, everyone. We now begin session 2 of day 4. The moderators for this session are once again Dr. Amrita Pathak and Dr. Soumya Pati, Associate Professors at AINN, and the rapporteur is Ms. Aishwarya, PhD Scholar at AINN.
Taking the session forward, we are delighted to introduce our next esteemed speaker, Professor Amal Chandra Mondal. Professor Mondal is a distinguished neuroscientist from Jawaharlal Nehru University, New Delhi. He earned his PhD jointly from Chittaranjan National Cancer Institute and Jadavpur University, Kolkata, and pursued postdoctoral research at the University of Illinois at Chicago, UIC, USA. His primary research interests include the neurobiology of Parkinson's disease, Alzheimer's disease, and depression. He is a fellow of the West Bengal Academy of Science and Technology and has been recognized with numerous honors, including the Professor A.K. Mukherjee Memorial Oration Award, PSI, and the Dr. A. Namasivayam Award, IABMS. We are honored to have you here with us today, sir. We now invite Professor Amal Chandra Mondal to deliver his lecture titled Neuropharmacological Interventions in Alzheimer's Disease, Molecular Insights into the Pathophysiology.
Okay, thank you for your kind introduction. So a very good afternoon to all of you. So basically, at the outset, I would like to thank Professor Malik and the IBRO organizing committee members for inviting me here and giving this opportunity to present my research work. Basically, I am working on the neurodegenerative diseases, and there are so many neurodegenerative diseases, and one of the important neurodegenerative diseases is Alzheimer's disease. So this Alzheimer's disease is basically known for so many years. So it was known by Dr. Alois Alzheimer in 1906. So it's more than 100 years past, but there is no remedy or there is no medicine yet developed to halt neurodegeneration. So that is how we are working on these neuropharmacological aspects. And I would be talking in two different things. One is basically the basics of Alzheimer's disease. There are 2 slides. And rest I would be talking on the hyposignaling pathway, one of the inhibitors that is called the MST 1,2, and the inhibitor's name is XMU-MP1, and we are working on this Alzheimer's disease on preclinical model. Okay. So if you see, this Alzheimer's disease is a progressive neurodegenerative disorder, and that is also irreversible. So there is a very similarity in dementia as well as Alzheimer's disease, but the basic difference is in case of Alzheimer, it is irreversible and the progressive neurodegeneration. And most common form of dementia, which declines in most of the cognitive abilities. And if you see the symptoms, there are many symptoms, and one of the major problem is the memory problem or the forgetfulness. There are other problems as well, like sleep difficulties and difficulty completing tasks, aggressiveness, social withdrawal, behavioral changes. There are a lot of issues with these diseases. And if you see the epidemiology of the disease, there were 46.8 million people. They were basically in 2015, this is the number. And this currently having 55 million people, they are surviving with the Alzheimer's. And it is expected to increase 74.7 million in 2030 and 131.5 million in 2050. So it is basically exponential. So the number of people they are getting affected with the Alzheimer's, it is basically exponential rate because of the life expectancy. So these days in India, we have like 72 years life expectancy. But earlier, if you see, like 1900, it was only 37 or 40 years of life expectancy. So because it is an old age problem, and it is not the normal old age problem, but it is basically the pathological problem. Okay, and if you see the state-wise prevalence of Alzheimer's, then the red mark you see, they are having the highest number of Alzheimer's disease patients, like J&K, West Bengal, and the Odisha. They are having the more number of Alzheimer's patients than any other states. So now you see there are 3 trees I have just presented here. One is very green, like these are like autumn fall tree kind of thing, the leaves are falling. So this is the young age, full of leaves, green leaves. Now as you old more, then you see leaves are falling, right? And last one, if you see, there are so many leaves, but they fall down. So this is the sign of the memory loss, because all the neurons were there once upon a time, because they have lost basically the cholinergic neuron in case of the Alzheimer's disease. So that is how the memory problem starts. So there are many theories of Alzheimer's. I'll brief very. One is like A-beta cascade theory. It is basically the deposition of amyloid beta. And this amyloid beta comes from the breakdown of amyloid precursor protein with the help of the beta and gamma secretase. So whenever there is more and more activated beta and gamma secretase, there is more production of amyloid beta, which gets deposited extracellularly on the neuron. So that is how the neuronal death. Another theory is called the tau protein theory. So tau is basically microtubule associated protein that helps in the structure of the neuron. How you see the neuron? We have a cell body, then dendrites, and one lengthy projection called the axon. And this tau, which is basically microtubule associated protein, helps in the stabilization of the structure of the neuron. So when this tau protein gets hyperphosphorylated, they get collapsed. So that is how another problem of the neuronal death. So third problem is basically the UPS impairment system. So UPS is called ubiquitinic proteasome system. Basically that clears whatever the debris or dead cell or the protein. But when there is an impairment of this UPS system, they cannot clear the aggregated protein, which is the here amyloid beta. Last is basically it is the death of the not all the neuron, but the cholinergic neuron. So that happens in Alzheimer's disease. So if we see the hallmarks of the Alzheimer's pathology, in the beginning, as I mentioned, it is called the A-beta pathology, because this amyloid beta is basically the toxic byproduct of amyloid precursor protein, which is cleaved from the APP by the beta and gamma secretase, and they basically deposited outside the neuron. So when this kind of depositions are there, which are not cleared, so other neuron cannot contact. So if there are 2 neurons don't contact, then there will be a neuronal death. Similarly, as I mentioned, tau hyperphosphorylation. Also, there is a increased oxidative stress and the mitochondrial dysfunction in case of this Alzheimer's disease. So as this A-beta deposition, tau hyperphosphorylation, so there is a indication of oxidative stress, also the mitochondrial dysfunction, This mitochondrial dysfunction is related with the mitochondrial biogenesis and also mitochondrial fission and fusion. So all these things gets impaired. One more pathological issue is ACHE hyperactivity. What is ACHE? It is acetylcholinesterase hyperactivity. This basically breaks down the acetylcholine into acetic acid and the choline. So in case of the Alzheimer's pathology, this ACHE hyperactivity is seen. When there is a increased oxidative stress and mitochondrial dysfunction, then you see the neuroinflammation. So neuroinflammation is the basically these brain immune cells. There are astrocytes and the microglia. They get activated and they secrete more and more cytokine and interferon, and that is how you see the neuroinflammation. There is also a problem of the synaptic dysfunction, because you see whenever there is a acetylcholinesterase hyperactivity, that means whenever acetylcholine is released from the presynaptic neuron, okay, so in the synapse junctions, basically it gets lost because of the hyperactivity of ACHE, and then you see the synaptic dysfunction. So ultimately you see the neuronal apoptosis and the neurodegeneration, and because of this neurodegeneration there is a cognitive impairment. So there are many pathological hallmarks that I summarized, and in the center that you see, the right side, it is basically the AD brain. So Alzheimer's disease brain is basically shrunk here, and there are so many vacuum region also you can see compared to the healthy brain. Oh, it's not working again.
So it's not, the screen is
The
freezing.
laptop is freezing. It's hanged right now.
Well, because of there are so many files in the desktop.
Could be, sir.
Yeah, no, that is the reason, because it is overburdened now, your desktop. Many diseases as well.
ये बीच बीच में हैंग क्यों हो जा रहा है?
कुछ सॉफ्टवेयर का तो दिक्कत होगी, क्योंकि अभी भी अपडेट हुए हैं नए सिस्टम में।
तो अब तो नहीं होगा। कैसे कर रहे हैं आप बता रहे, अगर आपने कैसे कर रहे हैं
Position, then other neuron cannot connect, because one is the extracellular position, another is the intercellular position. This tau is basically the intercellular position, and A beta is basically now it's moving. So basically today I will be talking on this hypo-signaling pathway. Mainly it was discovered as a signaling pathway that regulates organ size in the Drosophila melanogaster. But again, these hippo genes, they are conserved in many species, including human. So here you can see if there is any mutation in the hippo gene, that basically leads to overgrowth. And you see the hippopotamus-like structure, right? So this is the wild type Drosophila, and right side you see the hippo mutant. So wherever hippo mutant is a overgrowth or cancer like state, because there is no apoptosis, right? So when I come to this hippo signaling pathway, so there are two states. One is like hippo off, another is like hippo on, right? So when there is a hippo on, so you see there are many mediators and the activators, right? So the top one is the activators MST. It is mammalian SET20-like kinase, the MST. Whenever MST gets phosphorylated, it's basically downstream, all the molecules get phosphorylated, and it can't enter into the basically the nucleus, right? So that is the one problem. But whenever there is a hippo off, then basically no one gets phosphorylated, and it can basically, this last molecule YAPTAZ can enter, bind with the TEAD, which is basically binds with this nucleus, and the cell survival and cell proliferation goes on. That is how you see the overgrowth. It is like cancer-like state. There is no cell death, but here there is apoptosis because of the phosphorylation of MST. So many people reported that basically MST instigates this neuronal apoptosis. Then we thought, why not to try if we can inhibit this MST with an inhibitor? Then we see whether it is like we can prevent the apoptosis or not. So this is the molecule you can see. It is called basically the XMU-MP1, which is the inhibitor of MST. So we basically worked on this in the preclinical model, that is the rat model of Alzheimer's disease. So we induce Alzheimer's with streptozotocin that we will discuss. So these are the hyposignaling pathway and the neurodegeneration. There are many papers that suggest that yes, there is a relation between this hyposignaling pathway and the neurodegeneration, right? So, and the fundamental role is basically the cell survival, proliferation, differentiation, migration, and apoptosis. And there are stress signals as well that activates this hyposignaling pathway, including this Alzheimer's disease. And this hyperactivated hyposignaling leading to numerous diseases associated with the nervous system, and inhibition of MST1 phosphorylation by a chemical inhibitor that we use, XMU-MP1, that we will see what is the effect. So this was the hypothesis that the hyposignaling pathway might be acting as a key molecular mechanism driving apoptosis in the pathogenesis, and hyposignaling inhibition via this molecule XMU-MP1 may alleviate this Alzheimer's pathology. So we investigated the involvement of hypopathway and therapeutic effects of pharmacological inhibitor XMU-MP1 in a sporadic Alzheimer's rat model. So we use this streptozotocin as an inducer of sporadic Alzheimer's disease, because this streptozotocin makes this insulin-resistant brain state. That is how it is called basically the type 3 diabetes now these days, right? So there are so many studies that basically supports that streptozotocin acts, basically it induces sporadic Alzheimer's disease. So how it induces, this is a little bit molecular mechanism, how streptozotocin induces Alzheimer's disease. Basically this streptozotocin binds with these GLUT2 receptors. After binding with GLUT2 receptors, it damages the beta cells of the pancreas, and these beta cells basically release your insulin. And whenever there is a damage of beta cells, you see the insulin deficiency. And this insulin deficiency in the brain, that causes neuroinflammation. And neuroinflammation ultimately leads to neurodegeneration. On the other hand, this insulin deficiency basically impairs your insulin receptor signaling through GSK3 beta. And whenever this GSK3 beta is involved, you see the increased amyloid beta accumulation and tau phosphorylation. And this A beta accumulation leads to your development of senile plaque, and tau hyperphosphorylation leads to your NFT formation, which is called the neurofibrillary tangle formation. And this neuroinflammation and all these things leads to your neuronal and synaptic loss. So that you see the Alzheimer's disease. So this is our study, this in vivo study methodology. We used these adult male Wistar rats. We acclimatized them for 7 days. After post-acclimatization, we injected the rats with streptozotocin on the day 1. It is in the rate of 3 milligram per kg body weight. We injected streptozotocin through stereotaxic surgery. So after injection of streptozotocin, we allow them to recover so for 7 days. So this is called the post-surgery recovery period, 2 to 7 days. So on the day 8, we injected that XMU-MP1, which is the inhibitor of MST, as I mentioned earlier, at the rate of 0.5 milligram per kg body weight. And we also injected donepezil, which is the standard drug for Alzheimer's disease. So both we injected from day 8 to day 28. After that, we did a battery of behavior tests. Those tests are open field test, novel objective recognition test, Morris-Watermaid test on day 23, day 24 and 25, and this Morris-Watermaid for 5 days. On day 31st, we sacrificed them, isolated the brain, and we dissected out hippocampus and the cortex. So after dissecting out, we basically studied many biochemical tests, like oxidative stress parameter like reduced glutathione, superoxide dismutase catalase, their activity, and lipid peroxidation, and the protein carbonyl content as well. So these are the indicator of oxidative stress, as well as we performed this ACHE activity. We estimated acetylcholinesterase activity. We did some protein estimation through Western blotting. Also, we did some histopathological studies of these brain sections and also the immunohistochemistry as well. So basically, animals were divided into 4 different groups. One is SAM. Second group is called the Alzheimer's disease group. Third, this disease group is treated with the XMU-MP1. And fourth group we treated with our positive control called the donepezil. This is the standard drug used to treat the Alzheimer's. See, it's not working still. Again got frozen. Actually, there are many files in the desktop, and those are huge files. It's overburdened now, the desktop. You could paste it in the system. So, first we check the open field test. This open field test is to test the exploratory behavior. So, this basically open field box is divided into 16 squares. And if the rat basically sits in the central and explore whole the area, then we thought the rat is basically less anxious. And if the rat basically sits in a corner and explore very less, then we say it is very anxious, right? So Alzheimer's patient, they are also very much anxious. So we tested the anxiety and exploratory behavior. So we basically check there are 2 things. One is central square entries and the frequency of line crossing. So what we found that in case of the disease rat, Alzheimer's disease rat is having less central square entry compared to the SAM control. And whenever we treated with the XMU-MP1, which is the inhibitor of MST, that basically improved the central square entries as like donepezil. Similar findings we observed in case of the line crossing. So if you see the number of crossing, in case of the disease rat, they have very, very less, significantly less number of line crossing compared to the same control. And when we injected this XMU-MP1, it significantly improved the frequency of line crossings. So this suggests that XMU-MP1 treatment enhances the cognitive dysfunction in ICV STZ treated rat by improving exploratory behavior in open field test. So next we checked the novel object recognition test, or we call the NEURO test. It is basically the hippocampal dependent or hippocampal associated memory test. So basically in this test, rat was trained to these 2 particular objects. They are having the particular shape and size and the color. So rat was basically explored with this for 2 days training, and after 2 days, one object was basically removed and put a new object. So our normal rat, having the intact memory, will try to explore more this new object, new or the novel object having different shape, size, and color. But in case of the disease rat, they will not. So this is the first one is called the familiarization phase. Second one is called the recognition phase. And we checked 2 things. One is called the discrimination index, and second is called the recognition index. And if you see in case of the Alzheimer's rat, they are basically having very, very less discrimination index compared to this SAM controlled. And when we injected this XMU-MP1, it significantly increased the discrimination index. And donepezil, our positive control, also did the same thing. And in case of the recognition index also, you can see the similar results. So it suggests that yes, XMU-MP treatment enhances the cognitive dysfunction in streptozotocin treated rat by improving the object recognition memory in the NOR test. Next we test, it is called the Morris-Water maze test. This is another behavioral test also. Because why we test these things? Because Alzheimer's patient is having the behavioral problems. So that is how we try to check the spatial memory here, spatial memory and learning recognition through this Morris-Water maze test. So here basically rats are allowed to swim here in this pool of water, and one of the quadrant there is a submerged platform. It's a transparent platform, right? So the rats know where is this platform. So we trained them for 4 days, and we see the escape latency, time spent in target quadrant, and frequency of platform crossing through this test. And if you see in case of the Alzheimer's disease rat, they have the more escape latency compared to this control rat. And in case of the time spent in the target quadrant, also the same you can see, also the frequency of platform crossing. This is the track plots that you can see for 4 different groups. And this suggests that yes, XMU-MP1 treatment enhances the cognitive dysfunction in streptozotocin treated rat by improving spatial learning and memory retention through Morris-Waterman test. So one of the pathological issue is tau phosphorylation that we checked on this XMU-MP1 treated rat. So tau phosphorylation we checked through immunofluorescence. As you can see here, in case of this AD rat, AD plus vehicle control, you can see more tau phosphorylation compared to this SAM. And again, this AD plus XMU1 treatment, this basically increased. So here is the relative fluorescence intensity that you can see, the red bar, which is indicating the mean fluorescence intensity, which is increased in case of the AD rat compared to the SAM rat. Again, after injecting with XMU-MP1 in disease rat, it basically lowered down significantly. Same thing we tested through Western blotting as well, that protein expression, and you can see the similar results that yes, in case of this disease rat, the protein expression, that phospho-tau, it is basically increased compared to this normal one, and after treating, it basically goes down significantly. So this suggests that XMU-MP1 reduces tau phosphorylation in Alzheimer's disease rat. Another hallmark of the Alzheimer's disease is called the amyloid beta load, right? So this amyloid beta is produced by the cleavage of APP, amyloid precursor protein, by beta and gamma secretase enzyme. So whenever beta and gamma secretase are more activated, they produce more amyloid beta. So that is how there is a deposition or aggregation of amyloid beta, which is the outside of the neuron, which is the extracellularly. So we checked the APP expression, which is called the amyloid precursor protein expression through Western blot, and we did not find any significant change among the group. As you can see, there are 4 different groups, and also in 2 different regions. One is like hippocampus, another is the cortex, and none of the group we can see the changes in APP expression. But whenever we check the base expression, base is basically beta secretase, that basically cleaves your APP into A beta 40 or 42, which are very toxic and gets aggregated outside the neuron. So we check the expression, gene expression or mRNA expression of base 1 through qRT-PCR, and we have seen in case of the disease rat, they are having more base activity or base 1 mRNA expression compared to the SAM control. And when we injected this XMU-MP1, which is the inhibitor of MST, so it basically decreased modestly. Same thing we can see in case of the cortex region as well. Here we have found the A beta 40 expression. So this is the basically the toxic protein, one of the leading hallmark of this A beta pathology that we also measured in case of this hippocampus and the cortex region. So here you can see the relative fluorescence intensity. This is the picture, and this is the quantification of this A beta 40 expression, where you can see the A beta 40 expression in case of this disease rat having more than the SAM control. And whenever we injected our drug XMU-MP1, which is the inhibitor of MST, it basically significantly decreases in both the regions. One is hippocampus, another is like cortex. Then we checked the amyloid beta load through thioflavin T staining, right? So basically this staining is to measure the amyloid beta load. So we checked the thioflavin T positive area, which is basically increased significantly in case of the disease, that you can see the red bar compared to the SAM or vehicle control. And XMU-MP treatment basically lowered this THT area or THT staining. That means that amyloid beta load basically decreased with this treatment. So this suggests that XMU-MP1 treatment attenuates this A beta 40 expression and amyloid beta load in streptozotocin-induced rats. So oxidative stress is another important parameter. Whenever there is a more cell death, then you see this oxidative damage. And this oxidative damage we measured through different parameters. One is like reduced GSH level, superoxide dismutase activity, catalysis activity. Then we check the lipid peroxidation as well, the LPO level, and the protein carbonyl content as well, PCO. And last of all, we check the acetylcholinesterase activity, another pathological hallmark of the Alzheimer's disease. So what we see that in case of the GSH level, it is very, very less in case of the disease rat compared to the SAM. Same thing happened in case of the superoxide dismutase activity and the catalase. But in case of the LPO activity, the lipid peroxidation, that also gets increased, right, in case of this disease rat compared to this control, right. And PCO control, which is the protein oxidation, that is called the protein carbonyl content. After oxidation of the protein, that gets increased, this protein carbonyl content. So that increase you can see in case of the disease compared to this SAM control. So after the treatment, they are modestly down-regulated here. And ACH activity, that is another parameter that we also checked. It is called the acetylcholinesterase, which is responsible for breaking down your acetylcholine in the synaptic junction into acetic acid and the choline. And this acetylcholinesterase activity is also increased in case of the Alzheimer's disease, the red one that you can see compared to the SAM. And again, this XMU-MP1 treatment modestly reduced the activity of acetylcholinesterase as like donepezil does. Okay, so we checked all these things in hippocampus and the cortex, this oxidative damage and hyperactivity. So this suggests that XMU-MP1 treatment alleviates this streptozotocin-induced oxidative damage and acetylcholine hyperactivity in sporadic Alzheimer's disease rat. So whenever there is a more oxidative stress, then there is a increase in neuroinflammation. So this increased neuroinflammation we check through the astrocyte density or the GFAP positive cells through this immunofluorescence that you can see. So we checked this astrocyte density through this immunofluorescence, and we looked for GFAP positive cells here. That you can see increased in case of the red one, which is the Alzheimer's disease rat. They are having more and more GFAP number than the your control, SAM control. So after treatment, it modestly reduced in both the case, in case of the hippocampus and the cortex. Okay, so again we checked another neuroinflammatory response, which is the microglial density. So microglia is basically the resident macrophage of the brain that basically protects our brain from the rest of the body, right? So we check the microglial density through IBA1. This is the marker of the microglia that we check through the immunofluorescence here. So when we assessed this immunofluorescence, that indicates that IBA1 activity is more, or IBA1 positive cells are more in case of the disease rat compared to this SAM control. And after treating with our drug XMU-MP1, that basically significantly reduced this thing in both the regions, hippocampus and the cortex. So this suggests, okay, 1 minute. So whenever there is a more neuroinflammation, then they produce larger number of cytokines and interferon. So we checked the mRNA expression of these pro-inflammatory cytokines, interleukin-6 and TNF-alpha expression in both the regions of the hippocampus and the cortex. Here what you can see here, that interleukin-6 expression in case of the disease rat having more. This is the relative mRNA expression that is significantly higher in case of the disease rat compared to the vehicle control. And after treating with the XMU-MP1, it modestly reduced like donepezil. So donepezil is our basically positive control. That is the standard drug used in case of the Alzheimer's disease treatment. So similar thing, the TNF-alpha expression, also we can check the similar results in both the regions, hippocampus and the cortex. So this suggests that XMU-MP1 reduces neuroinflammatory response in Alzheimer's disease rats. So synaptic dysfunction is another hallmark of the Alzheimer's disease. So for the synaptic dysfunction, we checked 3 different synaptic protein. One is PSD95, second is synaptophysin, and third is synapsin-1. So they are basically synapse-specific protein, and we check the expression of the synapse-specific protein through Western blotting. So here you can see the PSD95 expression, which is basically reduced significantly in case of the disease model compared to the SAM control, and after treating with this XMUMP1, it significantly increased the PSD95 expression in both the regions. Similarly, the synaptophysin expression also basically reduced in case of the disease rat compared to the SAM control, and after injecting with this XMUMP1, it modestly increased in both the regions. And this synapsin-1 expression is done through this IFC or immunofluorescence here, so that you can see the similar results. So it suggests that yes, XMUMP1 treatment attenuates synaptic downscaling in Alzheimer's disease rats. So cellular apoptosis is the ultimate thing. So we check the pro-apoptotic and anti-apoptotic. Okay, pro-apoptotic and anti-apoptotic proteins like BAX-BCL2 expression, and we checked the ratio of the BAX-BCL2 expression, where you can see the increased ratio of BAX and BCL2 expression here in case of the diseased rat compared to the SAM rat. And whenever we treated with our drug XMUMP1, that modestly reduced the expression of BAX-BCL2 that you can see. And we also checked the another apoptotic protein, which is cleaved caspase 3, that we also found the similar results. Okay, so it suggests that XMUMP1 attenuate neuronal apoptosis in AD rat. We also check the neurodegeneration through Kessel-Violet staining. That we basically, if you see the in case of the SAM, there are the round nuclei that you can see on the normal cells, but here in case of the disease rat, that you can see the pycnotic nuclei, and there are most vacuolar in region that you can see. But after treatment, most of the cells, it got very normal compared to the Donepezil group. Also, we check the BDNF, brain-derived neurotrophic factor, which is the survival and differentiating of the neuronal factors, which is the BDNF, that also we checked. And because of the shortage of time, I cannot cover all these things. And also we checked the NEUN and the MAP2. They are the mature neuronal marker through this immunofluorescence here. And yes, we got in case of the disease rat, the NEUN expression is significantly lower compared to the SAM control in both the regions, hippocampus and the cortex, where it increased after the XMUMP treatment. Same scenario you can see on the MAP2 expression as well. So it suggests that XMUMP1 attenuate streptozotocin-induced neurodegeneration in AD rats. So also we checked some of the downstream pathway of the hyposignaling. One is like PMST, so phospho-MST and versus total MST, also the PLATs versus the LATs. So these are the downstream signaling pathway of these hyposignaling that we checked through immunofluorescence as well as the Western blotting here, and you can see the similar results here because I don't have more time to speak all these things. And also we checked the phospho-YAP expression, because this is the YAP that basically get translocated in the nucleus and binds with the transcription factor. That is how it can prevent the apoptosis, right? So we check the phospho-YAP expression in case of this Alzheimer's disease rat through this immunofluorescence here, that you can see the expression here in case of the Alzheimer's disease and the SAM control. Here you can see the phospho-YAP expression is basically highly expressed in case of the significantly higher in case of the disease rat compared to the SAM. Same thing you can see the total YAP, there is no differences. And also if you see the nuclear localization of YAP, there you can see also that in case of the disease rat, here is the down, the red one is basically down regulated here compared to the control here. So it suggests that yes, treatment with XMUMP1 suppresses hyposignaling activation in AD rats. So to conclude, streptozotocin administration induces hippopathway activation. MST1 phosphorylation leads to Wnt signaling inactivation, which causes beta-catenin degradation, and hypoactivation and Wnt suppression induces AD-like pathophysiology. This is followed by nuclear translocation we checked also. So this paper is published, this is only paper. Whatever I told you, this paper is published in Apoptosis journal. The impact is 8.2. It's a spring journal. And this work is done by my student, Manos Ranjan Sahu and Mir Hilal Ahmed. So I did nothing for this work. They have already done everything. So finally, I would like to acknowledge the DBT funding agency who has given us money, and the student basically who has done this work, CI facility, staff of SLS, and the CLAR facility. So if you have any question, I would be happy to take.
The forum is now open for discussion.
Yes.
So, really lot of work and wonderful talk, definitely. I just have two questions. One is that you showed BDNF expression in the enhance. So, what can be the possible mechanism that induce the BDNF expression there, using XMU treatment? Second, sir, do you see also enhanced neural precursor migration to the site?
No. Both we didn't check.
Okay.
How it's basically migration, other thing we have not checked. We have checked only the expression only.
Yes, sir. Okay. Thank you, sir.
Since we are running short on time, this will be the last question for this discussion.
Wonderful
round.
presentation, sir.
Thank you.
I was wondering, like, since you have taken the whole cortex,
yes.
So does the Alzheimer's disease progression would vary across the frontal lobe or the parietal cortex? And would taking these two brain areas separately would give a different view, or these oxidative markers would vary?
Yeah, actually that is how we have chosen only these two regions. One is hippocampus and another is cortex. If you see the MRI, the region which is basically degenerated, this cholinergic neuron, this cholinergic region is basically your hippocampus and the cortex. They are basically affected. That is how we have chosen this thing. And it is not the death of all the neuron in case of the Alzheimer's disease. It's very specific, the cholinergic neuron, which is, there are two regions. One is like hippocampus, another is cerebral cortex. So we have checked only these two regions only. We have not checked any other region. No, actually we have taken whole cerebral cortex. Yeah.
Thank you everyone for your active participation. Thank you, sir, for that insightful and enriching talk. Your exploration of neuropharmacological mechanisms adds significant depth to our understanding of Alzheimer's disease. We now request the moderator of the session, Dr. Soumyapati, to kindly honor the speaker with a token of our respect. Thank you, ma'am. We are honored to introduce our next distinguished speaker, Professor Gurcharan Kaur. Professor Kaur has played a proactive role. We are honored to introduce our next distinguished speaker, Professor Gurcharan Kaur. Professor Kaur has played a proactive role in human resource development in biological sciences, serving as the chairperson of the DBT Government of India-sponsored MSc Biotechnology program and Dean Faculty of Life Sciences in Guru Nanak Dev University, Amritsar, where she has served since 1985. She is a fellow of the Indian Academy of Neurosciences and the recipient of the B.K. Bachawat Lifetime Achievement Award. We're deeply honored to have you here with us today, ma'am. We now invite Professor Kaur to deliver her lecture titled Validation of the Neuroprotective Potential of Tinospora cordifolia using in vitro and in vivo model systems.
First of all, let me thank Professor Malik and his team for giving me this opportunity to share some of our work with you all, the youngsters. In fact, my aim here is not to talk about what we have done, sharing all the data, but some of the important things which we realized during our journey when we were working with this plant, Tinospora cordifolia. Sorry, what happened? Okay, so this is the tree. So as you know, Tinospora cordifolia, also known as Giloy or Guduchi, and in Ayurveda is known as heavenly elixir or Amrita. And believe me, during our work with this plant for 15 years, we started in 2011 until 2025, we have been working with this plant. It stands for its name, Amrita or heavenly elixir. I'll share some of the findings from our lab, but being a retired person, I'm more of a storyteller now. And the today's story is about Amrita or the Tinospora cordifolia, how it worked in our hands, and what are the hiccups, what are the things we need to keep in mind. See, Ayurveda is India's heritage. But honestly speaking, if you go to the market, want to buy some good product, which is reliable, which works all the time, for the natural products, I'm sorry to say, we don't find any. So what are the reasons? Why, in spite of the fact that Ayurveda belongs to us, it is our heritage, but still we are not able to have good products. You go to America, you go to some other developed countries, you get a good product there, but not here, okay? So I'll be talking about some of these things, why we have, where and why we have failed somewhere in promoting our own heritage. So as I have mentioned here, this particular plant is known for many of its activities, especially for the hepatoprotective role. So when we started working with this plant in it's not working again. So when we started working with this plant in 2011, and the first paper came in 2013, and the last we published in 2024. So we started working with this plant, the stem of this plant. Now here, what is important, when we work with the natural products, first thing we need to know is that what is the elite variety available to us, because when we even if you have an elite variety, when it is further propagated, it loses its properties. And second important aspect about these plants is that in spite of the fact that you start with the elite variety, but what is the age of the plant when you are harvesting for using for a particular activity? And second is, what is the season of harvesting? No? When we use natural products as a concoction, as a mixture, as an extract, it is multiple components. It targets multiple pathways. That's why these natural products have multiple activities, or we'll end up with mostly the rejuvenation. Okay? But if we are selecting a plant at the wrong time, harvesting a plant at the wrong time of the year, and the age is not kept in mind, what we'll end up is not with the appropriate concentrations of these active ingredients, which together bring out a particular, antioxidant or anti-cancer or hepatoprotective, whatever activities you are studying. So it is very, very important that when you pick up a plant, first of all, see what is the best time of harvesting, what's the variety available, and also what is the age of the plant, which will give me the right combination of the ingredients present in that plant. And also, another important thing is most of the time I come across youngsters come up with the projects mixing plant A, plant B, plant C, plant D. Mixture of plants. Without going into the background, what is my purpose? You hear that this particular plant has this property, the second one has this property, and you just want to, again, use a mixture of everything, and you'll land up nowhere. So it's very important that, first of all, as Dr. Sahila also very nicely explained in the morning, conceive an idea, what you want to do, and then go about it, search into literature, look for what is the right variety and what are the other parameters I must keep in mind. Okay? So when we started working with this plant, another important aspect is plant has roots, stem, leaves, fruits, seeds, and okay? So you should know which part of the plant. If that knowledge is not there in literature, do some preliminary work to find out for one particular type of activity, say for anti-cancer, which part of the plant is giving me the best results. Then I go further working with that. So what we came across from literature was that for giloy, it is the stem of the plant. Second, January is the best time to harvest. Third, when the stem is brown in color and almost finger thick, adult finger thick, that is the right part of the stem which you should pick up for your work. So what we did, we made this collection from a particular region, a particular season, and the stem was then shade dried, and then we ground the powder. Now here our objective was to scientifically validate the traditional use of this plant, not for the activities which were already known, but for anti-brain cancers and also for the anti-obesity and anti-anxiety effects. Okay? So we first started with 50% hydroalcoholic extract, and we tested the anti-brain cancer activity. I'll show you some of the data later. Then we started working with different fractions, prepared different fractions based on polarity, and tested each of these fractions for the anti-brain cancer activity. What we found was that chloroform and hexane fraction, they gave good anti-brain cancer. We used the cell lines like C6 glioma and MG87 glioma cell lines, and also the this IMR32 and SHSY also. So what we found was that chloroform and hexane gave anti-brain cancer activity, ethyl acetate was not active, and butanol fraction was not also active for brain cancers activity. So we did some further experimentation with this, but we got more interested in the butanol fraction because what we observed, one of my students during her PhD, she did a lot of further fractionation and analysis, and then finally even she came out with the single compound, tinosporicide from the butanol fraction, which we tested for the neuroregenerative branch because we got interested to know more about its neuroprotective because literature didn't have much about the neuroprotective role of Tinospora cordifolia. So what we did was we used a simple model system of the primary neurons, telling them with glutamate. You all know what is the role of glutamate overexcitation causes damage. And then we treated it with the butanol fraction, and we could see the recovery or the cells, they were now rescued from degeneration. Now look at these figures. We used butanol fraction at 20 microgram per ml, and this active ingredient which we recovered, it was 25 nanograms per ml, almost 800 times less dosage. It worked the same. But since our main aim was to look for the scientific validation of the use of this plant we didn't go further into these single compounds. We were not much interested, although we did find one, but we concentrated most of our studies later on scientific validation using the whole stem powder or the butanol extract. So here my, again, advice to the youngsters here is, when you are working with a cell culture model, it's very important that after all your aim is to project it, extrapolate it for some translational value, okay? So when you are selecting your model, you should be very, very particular to know what is your choice of the cell line and what is the source, the authenticity or the reliability of that cell line. And second is, when you go for primary cultures, first see whether it is possible to even establish primary culture for that particular activity. If I talk about brain cancers, the only way out I have for brain cancer in primary cultures is to go for some surgical samples and then set up the primary cultures, which is not always possible. So you choose the right type of cell line and preferably human cell lines, so that you can go more closer to your goal of translational research. And also, what should be the protocol for exposure to the test material? Whether, depending upon what you're looking for and what is the aim, if it is care or cure, care versus cure. If it is preventive, I would say when we talk about natural products, Ayurveda, it's more of prevention than treatment or the cure. So pre-treatment or the post-treatment is also very important to be kept in mind. And how do you collect the sample after exposure? It also depends on the technique you are using further. If you want to go for localization in the whole cell, like ICC, immunocytochemistry, then there is particular way how you seed the cells on the cover slips in the multi-well plates, and then pick up those cover slips and go for immunostaining. But if you want to go for Western blotting, you have to use 6-well plate or the 96 millimeter, these Petri dishes, and you scrap the cells. So all these things, you as a beginner should know how I am going to select my cell line, what should be the authentic source where I can get those, and also you should familiarize yourself with the cell morphology and a particular cell-specific target molecule. You can go for immunostaining to make sure, yes, if I'm using glial cells, I go for GFAP staining, and I should see the staining in the cells, and then only I go further, not before that, okay? So these are some of the pathways which we then explored: cell survival, apoptosis, senescence, and anti-inflammatory. And to start with, of course, we first, after getting the right type of extract, we expose the cells, C6 or IMR32 cells, to the different concentrations to know what concentration actually is not toxic to the cells and gives me anti-proliferative activity. That is based on MTT assay. And then we did this flow cytometry to know the number of cells which have entered into the apoptosis, and it should not be necrosis here, because if it is necrosis, it's not like giving you any outcome. So what you will actually see is that you should get early or late apoptotic cells if it is really showing any anti-cancer activity. So our MTT results gave us this 2 dose where it was not, necrotic. And also, we wanted to see at which stage of the cell cycle the exposure to these extracts is blocking the cells. Okay? So, and also by immunostaining, as you can see in this slide, we did phase contrast, and then with alpha tubulin, you can clearly see the whole cell morphology, and we did some active known markers of the neurons, and also for the glial. I'm not showing all the data here. And cross-checked with the protein, not just the localization of the protein, but also by the total protein content by Western blotting. Now here again, when we go for Western blotting, very, very important that we have an internal control. So what is internal control? Internal control is a protein which is constitutively expressed, and even constitutively expressed protein sometimes does not give you good results. Like if you pick up some, say, treatment which is blocking the, or which is disorganizing the microtubular proteins. So alpha tubulin is a microtubule protein, so that will be affected. We have seen some of the drugs which we were using was also tampering with the alpha tubulin. So you have to be very particular. See, yes, the drug or the molecules or the extracts you're using are not tampering with the alpha tubulin. So your internal control is basically to rule out any hand error, or we call loading error. When you're doing electrophoresis, you all must be familiar with that you load your sample. First is you prepare your sample, do the protein estimation, equalize all your samples should have, your control, your test should have equally like the same amount of protein. Because what you're looking into this Western is up and down regulation, no? The size of the band. So this size of the band should not be due to your hand error or due to the loading error. That's the very reason we take the alpha tubulin or any constitutively beta-actin or this GAD, DH, all these proteins, they are being used as internal controls. And finally, when you present your data, you present intensity of this divided by intensity of the internal control. It's a ratio. So in the ratio gives you the difference, that is the actual change which you are getting in the protein. See, if your alpha T is also increasing and decreasing, it will not be reflected in the change. So ideally this should be constant. As you can see, all the three bands giving almost the same intensity. That means whether you loaded control or the test, there is no difference in the protein amount which you have loaded in the gel. Another simple test for anti-cancer activity you can do in the cultures is the anti-migratory, or we called wound scratch assay. Okay? So wound scratch is when you make a confluent growth of cells on a cover slip in the multival plate and then make a scratch with the help of a micro pipette tip and then do whatever treatment you want to give and see whether the cells are able to migrate into the scratched area or not. So you can see here the control cells, this is a C6 glioma which is highly proliferative, doubling time is about 10 hours. So in 6 hours, the scratched area was repopulated by the cells, whereas the treatment wells, there was very less migration. So this is again a very good test, very simple and a very good reliable test to find out the anti-proliferative as well as anti-migratory activity of the test compounds. And also these MMP matrix protein proteases enzymes which are responsible for the cleaving of the extracellular matrix, you can just pick up the media and go for Zymo, this gel running, and you can find out change in the expression of these proteins, although here we didn't find much difference. And similarly, we further did some experiments with the, after in vitro, you can go for sort of ex vivo. So you do the explant cultures. You take the small piece of tissue and expose them and see whether the cells are able to migrate out of that explant or not. So here you can clearly see the treated cells, both the BTC alone and in the presence of after challenging with glutamate with BTC, there was migration of the cells from the explant. So these are some of the simple model systems one can employ depending on what is the requirement or what is your idea of working with a particular plant and a particular cell line. Now, since I told you we were mainly interested in scientific validation of the use of this plant, so we did look into some of the lifestyle diseases. We all know what is the scenario, current scenario in the, now we have got control over, I can say, infectious diseases. Corona is one example before us, where less than a year we had the vaccine available, but where we are failing ourselves is the lifestyle diseases. So lifestyle diseases, as you can see the expression of all these diseases, what are the root causes? Root causes are inflammation, stress, poor diet, toxins, lack of sleep, relationships, okay? And then toxic thoughts, negative attitude in life, traumas, genetics, and poor digestion, okay? So we did some study with the obesity model. Here again, now when you want to pick up a right kind of model for obesity, say for animal studies, now obesity is due to genetic causes, obesity is due to lifestyle, and obesity can also be due to some hormonal or physiological reasons. Now we just concentrate on this, that we are playing with our lifestyle, unhealthy lifestyle. So eating unhealthy and eating late, okay? As we know, nature has provided us with day and night, and automatically the body digestion metabolism slows down towards the evening. So when we eat late and we eat unhealthy, we eat food which is high on sugar, salt, and fat. So, and this problem in our youngsters, in the children, with the couch potatoes, clinging to the TV screens or the phones. So there is no activity, there's no mobility or very less mobility, and eating unhealthy is leading to the problem. We have done recently a project with DST, that's childhood obesity, how it impacts the mental health of these children. And it was very alarming. We worked with about 1,500 children from the elite schools. 30 to 40% of the children are already in the overweight, obese. We did a lot of neuropsychological testing in them, their learning, memory, focus, their eating habits, the eating behaviors, cognitive restraint on eating, and all those factors, they are alarming. This is where we are heading to, but we need to sit back and think of where we are going and how we can easily stop all this, okay? Now, one of the models which we used here was a midlife transition in women. We all know as the women transit through this phase, there is flattening of the neurological health, there is increased adiposity, weight gain, and dyslipidemia, there is frailty due to muscle mass and bone mass loss, and there are inflammatory responses responsible for all the comorbid conditions as well. And the respite which they get by hormonal replacement therapy has its own set of problems. So what are the potential therapeutic windows we can look into? And this is what we actually thought of then doing with this plant. And again, I would suggest that when we are selecting the animal models, first of all, what is my purpose? What should be the right model for my study? By doing anti-cancer, especially peripheral cancers, you cannot use a normal animal, you have to use a athymic or nude mice. Otherwise, your cell-mediated immune response is going to take care of the cells which you inject to induce the cancers. But for brain cancers, brain being an immune privileged organ, you can directly inject the cancer cells into the brain, and you can develop the tumors in the poor animals. They are at our mercy. So we can induce these cancers. So what is the right approach? What is the right type of animal and the state of animal? And for lifestyle models, again, what is the right time, right type of approach I should use, animal as well as the I'll just go back here. So the problem of obesity, if we just forget about hormonal and the genetic factors, the epigenetics or the environmental factors are lifestyle. Okay? So we generally use rats or mice which are fed high-fat diet. Now, if I use high-fat diet and I start this experiment in the month of June, if I tell you eat mungfali and gachak in the month of June, would you prefer? No. Okay? Any high-fat pinni or what we call all these desi ghee ka saman, we don't eat in the summers. Our urge is not there to eat that stuff in the summers. So it is very important when you are using a high-fat diet-induced model system, what is the right time of the year when you start your experiment? Especially, even if you are sitting in the AC room, you will not eat those stuff, which we generally eat in the winters, okay? And also, this is also important, we have published one paper in Nutrients. It says like, we are what we eat, we say. Whatever we eat, we become that, which is also true. But on the contrary, it is also true that we eat what we are, our culture. You go to any part of the world, after 2 or 3 days after eating the local food there, you will search for your own food because we are used to, that's our culture. This is how we have been brought up eating those materials. So as a Punjabi, I'll always look for kake da dhaba somewhere. Okay, so that's very, like it's obvious. It's not just we are posing, but this is how we are. So here, I just wanted to emphasize that when we select a model, what animal and what time of the year, what type of treatment, how much high-fat diet, which matches with my goal of what I'm looking for in the obese subjects, okay? So here we made a very, we were also amazed looking at these results that these animals, when we started feeding them in the month of November in Amritsar, starts cold weather, and it went up to 3 months we completed in the month of February. So what we observed was that these animals, they were fed with the whole, stem powder, and these animals supplemented, high-fat diet supplemented with the stem powder. They consumed more diet, but they maintained the body weight in the face of consuming more diet. That was very interesting, and also we wanted to see what is happening. Like, they're eating more, but they are gaining less weight. So we looked into the lipid profile. I think I have that slide, yeah, here. So we could clearly see the cholesterol levels, the good fat, the HDL was increasing, and the triglyceride levels, you can see in the normal diet and the diet supplemented with the stem powder. Okay, so that was very interesting to know. So we further got interested, how come there is correction of the dyslipidemia and also the weight management. So we wanted to look into all the different wings of lipid metabolism. Okay? First we worked with the AMPK, which is a master energy regulator of the metabolism or the whole metabolism. And then we looked into the fatty acid synthesis pathway, lipolysis, beta oxidation, as well as the cholesterol biosynthesis. So I'm not going to explain each of these slides. You can always read our papers. But yes, we got very encouraging data with the treatment where we could see the lipolysis as well as the fatty acid synthesis. There was very significant downregulation in the biosynthesis of the fatty acid. So we could clearly then say that yes, with the treatment, with the dyslipidemia correction is happening because there is this biosynthesis of the fatty acid, triglycerides, and the LDL, and also the cholesterol, there is downregulation. And along with that, we did some other studies for the neuroprotective role, and here we can, we did this cognitive functions as well as the anti-anxiety test using the elevated plus maze for anxiety, and then also the NOR, the novel object recognition test. I just picked up the slides at random because my idea was not to dump you with all the data we have generated, but just the ideas behind. So here again, when we talk about the animal behavior studies, you want to study the anti-anxiety effect, and you want to study the, see the learning and memory. Okay. Now when you're planning these tests, it's very important to keep in mind that I should not do the anxiety test and immediately followed by learning and memory. Because once animals are anxious, their learning and memory will be affected. So it is very important to keep that in mind, that when I plan the anxiety test, and when do I plan the learning and memory test, and when do I plan the motor coordination or rotor-road test. So all these behavioral tests, as you have been listening today and also previously, they are all very, very important starting points to go for translational research, and then we'll go into the mechanistic aspects. But then what test and what time? When I plan experiments on the animals, I should clearly know that where a particular test needs some pre-acclimatization or where it does not require. So you should know the in and out of that test, significance of that test. Okay? So this is the rotor road, where we measure the number of falls and the grip, to measure the grip strength, we do the simple rotor road test for grip, this number of falls and the time they stay on the rotating road. Okay. So this was about the little bit of data I shared. Now my main concern has been throughout our studies is that be it our ministries, faculties, or departments of health, most of the biomedical research is directed towards disease-directed thinking. That means we first allow the disease, especially I'm talking about the lifestyle diseases, where again it is due to our unhealthy lifestyle. If it is genetics, if it is some hormonal, it's beyond our reach sometimes, beyond our prevention capability. But when we talk about the lifestyle, due to unhealthy lifestyle, eating late, eating unhealthy, taking a lot of stress, keeping negative attitude in the against my other. You remember the 3 idiots? One sentence, should I say, or you know? All is well, yeah, but another statement Amir Khan gives, I never knew, जब आप खुद हारते हो तो आपको इतना दुख नहीं होता, कोई किसी दूसरे के जीतने पे कितना दुख होता है. तो that negative attitude, no? तो ये सारी movies हमें बहुत कुछ सिखा के भी जाती है ना. So this cure versus care. Okay? So care, if where possible, why not go for care? So self-management, self-sustaining interventions, adopting simple, healthy lifestyle. Why can't we go for that? Again, it stops. So as far as the work with the natural products is concerned, all we need to keep in mind also is to join hands, work together in the research labs and in the herbal consortiums which are responsible for the propagation of these elite varieties which we develop in the research labs, and then the industry which prepares the formulations to be given to the practitioners. So all these 4 wings, we need to join hands and to make sure that the products we are using or the type of research work with all these different factors, keeping in mind we are now giving this technology or elite variety to the herbal health research, consortiums where they are propagating, and then industry is preparing those formulations, and the practitioners are then using it for the treatment. Okay, so this cure versus care model, I always like to share this slide with my youngsters, that we have this, say, Ayurveda and meditation and yoga, it's India's heritage, okay? Even healthy diet and intermittent fasting, basically, is, again, fasting is India's heritage concept. And of course, India is a land of no dearth of sunlight most of the time in the year, and the socio-mental engagement. Okay? Any time of the day or night, you knock at the door of your friends and the family, you are welcome with a cup of tea and whatever is there in the fridge to offer. That type of culture is nowhere in the world. And when we talk about aging science, we talk about 4 factors: diet, physical activity, sleep, and top of the line is socio-mental engagement. Okay? So if that is our India's heritage, why we are known as diabetic hub in the world? Something to seriously think about it, which is very unfortunate that we know there is a demographic shift in the population now, because birth rate is going down and life expectancy is increasing because of all the technologies and all the drugs, medicines which are available. But that life extension or longevity, there's a lot of now talk about longevity, but if that longevity is disease adjusted life years daily, it's of no use. What we want is healthy lifespan, not just longevity with the disease. Okay? But that is something which we can definitely think of. This is the city I come from, city of Golden Temple. All are welcome to visit us. And this is my contingent, sorry. This was actually my retirement party and the women power. But yes, I had end of the day 50% boys and 50% girls. It just so happens that at the time of my retirement, there were more girls in the group, but overall, there was 50-50 boys and the girls. Thank you very much.
The forum is now open for discussion.
So that was a great talk. And I like the way you started with the plant extracts, because they are available in India, but not much research is done. So I want to know what is a good institutional source where people like us, like I started my research recently in India, where we can reach out and we can easily get the plant extracts in their best form so that we can directly use it for our experiments either with animals or cell culture models.
Okay. First of all, to answer your question, we are not lacking in research. We are lacking in regulations. Okay. So as far as lab work is concerned, I know many of the institutes. And for your second question, I know some of the places like Triple IIM Jammu. We started from Triple IIM Jammu.
Okay.
That's one place where a lot of quality work is going on with the natural products. CMAP is another one. Okay? So there are places, all you need to do is to first sit back and look into the literature, look into the publications from some labs and then compare them. And think of which of these publications make more meaning to you. Okay?
Sure.
Do you find these critical assessments in those publications or not? How they get the sample? Because every publication you have to mention what was the source and where it is submitted, the voucher number and everything, no? So that is very important. Same is true with the cell lines and the animals. Okay, so you must go for a reliable, and also when you get a cell line or a product, don't depend on what you get from the background. Do your own initial testing. Make sure. If I'm getting HapG2, it is liver, it's not some other epithelial cell line.
Yes.
Okay,
Yeah,
if you're
that's
getting
important.
C6 glioma, it should not be some other cell line. So always when you start working, when you write a project, do some, keep some grant for the preliminary marker studies, be it plant or the animal or the cell culture. Always first look into those specific, species specific markers. Make sure that you have the right sample, right animal, right type of cell culture in your hand.
Sure.
Thank you.
Yeah. Since we are running low, do we have more questions? Okay.
Wonderful work, ma'am. I was just wondering, when you said that you have given high-fat diet to animals in November, did you compare the high-fat diet given to animals in summer region? Did you
We did not go because we know that summers, the animals, because one time by mistake our students started feeding them with the high-fat diet in not in June, but sometimes in September, October, and it didn't work. The intake was very less. But then we thought of that what is happening, why they are not eating properly. So then we came out that it is the season and the temperature, environment, it matters. Even if the animals are always kept in the air conditioning, but still it did not work. So it is very important that, see, it is not just the temperature, it is the day and night cycle, everything, no, it counts. Although again you are keeping a photo period, 12-hour dark, 12-hour night, but that's artificial light. But somehow that time of the year and the temperatures, the environment matters. And also another important thing is that you want to have a model for some translational value. And we know as humans, even if we are given all the time AC rooms, we won't eat that stuff in the summers. We don't have that urge to eat. So we should create the model which is matching with the human behavior.
Thank you.
Thank you, ma'am, for that illuminating presentation. Your work on herbal neuroprotective intervention truly exemplifies the promise of integrative neuroscience. We now request the moderator of the session, Dr. Amrita Pathak, to kindly honor the speaker with a token of our respect. With that, we conclude the scientific sessions for day 4. We now request all participants and faculty members to proceed to the laboratory sessions, where today's concepts will be explored through hands-on experiments and interactive learning. Thank you.
There's a small announcement. Today, after the lab sessions, we will also have one electroencephalography session in the human system. Okay, Gentech will be bringing their system, and there will be a demonstration of that. So I request all of you to please, after completing your session with the respective labs, please be available in 115A to have the demonstration of the EEG machine on the human system. Okay, thank you.
As we bring day 4 to a close, we extend our heartfelt gratitude to all our speakers, moderators and participants for their active engagement and valuable contributions. We look forward to seeing you tomorrow for final day, day 5 of the IBRO APRC School 2025. Thank you and have a pleasant evening ahead. हाँ जी सर मैं ये एंड करके